Oh, but it's so perfect.
All right.
No,
Welcome, everyone,
anyway, yeah.
to Recovery Council. We have names, I don't think we need to introduce yourselves. I will say, welcome to anybody who's online listening in. Thank you for joining us and for caring about the people in Maine and what we do for recovery here in the States. Appreciate it very much. I do know that there's one member that I know of the council, Representative Kraft, who has a hearing, and so she will be a little bit late. And Courtney has shared with us that she may have to, I hate to review, so I'm going to show my age, skedaddle at some point in time, briefly, to leave to do some business. Other than that, we will proceed. I want to thank Brandon and everyone for getting us the snacks. Please help yourself. There's water, coffee, pickles, some fruit. We will take a break at some point, but help yourself to that. Make sure if you have to stand, do what you need to do to go on. You have an advanced agenda. I don't know if you have, it's a busy agenda, but I don't know if you have anything you wanted to add to that agenda or something we missed in not putting it on the agenda. Okay, so the first order of business is to approve the, was that the last time we met? February 14th meeting 2023. You should have received those minutes or reviewed them on the website. If you have any questions other than that, I'm looking for a vote. Second move, what's the second? Any discussion on the minutes? All right, we'll do a show of hands. All in favor of accepting minutes? Any opposed? Excuse me, because there's people listening in. I think it was unanimous. There was nobody opposed and nobody abstained. So motion carries. Thank you very much. All right, so we are fortunate today. One of the things we talked about, what we wanted to know as a council is, where is the state? What is the state doing? How are we doing? What do they see is going on? And so for about 2 hours, we will go through the state's presentation, and you will be able to, of course, ask questions, and if they can answer, I'm sure that they will bring back to us the information that we're looking for in order to move forward.
Presentations are hard.
Oh, okay, so over there, you just reminded me, there is presentations, hard copy, and I think a copy of the agenda is over there also. All right, so Brendan, do you want to introduce who is here?
Sure, I'll try. We have today the director of the Office of Behavioral Health, Sarah Squirrel, within DHHS. I didn't prepare any more of an introduction than that. So I can't go through your credentials, but happy to turn that over to you if say anything further.
Sure, yeah. Well, good afternoon, everyone. Great to see you all. My name is Sarah Squirrel. I serve as the director of the Office of Behavioral Health. Very happy to be here. Moved to Maine just a couple of years ago. I served as the Commissioner of Mental Health in Vermont for 3 years prior to moving to Maine. So very grateful to have the opportunity to serve here in Maine, and looking forward to sharing some of the work that we're doing related to our opioid response, data, etc., with the council today. So thank you for having me.
Thank you very much. And I think part of it, so as we've talked about previously, the presentation today is, in my mind, is sort of thought of, here's the information that the state has about the opioid crisis. As we go through this, there's going to be opportunity at the end for Q&A. I've encouraged Director Squirrel, and I'm going to encourage the council to take as much time as you want for the presentation, and to take as much time as you want to ask questions at the end, or I guess it's up to you about if you want to take questions throughout. But take as much time as you want. We have Director Squirrel here. It's a great opportunity to, dig into the details, and to, find out as much as you want to find out about the state's information about the opioid crisis. I think it's likely that as we go through this, we'll identify where we don't, information that we don't have. And others in this room may have information that that the state doesn't have, or may have suggestions on where else to look for information that the council may want. But at the moment, this is the state's perspective. At least that's how I would characterize it. And I see Ben's joined us as well, so I'm just doing a bad job of introducing Director Squirrel and the point of the presentation. So take it away.
Okay, great. And just by point of order, I do have a couple members of the substance use team here from the Office of Behavioral Health, Catherine Rutu and Madison Barassa. So would they be able to answer questions as they come up if needed?
Yes, it's your presentation.
Wonderful.
If
Thank you.
one of the two of them have the answer and you don't have it at the top, please, and it's their expertise, please do that. And I'm going to ask a question. Would you prefer to wait for questions at the end or questions as you go forward?
We're going to cover quite a bit of content and quite a bit of varied content, so I'd encourage folks just to ask questions as we go. That's probably going to be easiest for folks in trying to hold them coming.
Thank you.
Wonderful, great. Well, I will get us started. Again, grateful to be here today. Also grateful to be in a room and just acknowledge the expertise and leadership around this table. I know we all feel such a strong sense of urgency as it relates to our opioid response here in Maine. I think we'd all agree that no single group or approach is going to solve this, that we really need a collective answer. And that's, I think, what the council represents, is the opportunity for us to work in partnership with a shared vision and shared goals. One thing I learned in my work in Vermont and here in Maine is that sometimes we think our best way to serve the system is to optimize pieces of it. I think we need to optimize the relationships between the parts to get the outcomes that we're after. And that's the real opportunity that I think we have here to leverage all of our respective resources across the state of Maine to continue to combat the opioid epidemic. So I was provided several areas in terms of an agenda to cover. So those areas, this presentation is projected up on the screens. I believe there are hard copies over here for folks as well. So I'll just run through kind of the table of contents and the content I hope to cover this morning. First, we'll be looking at some of the indicators that we utilize at DHHS related to the opioid crisis here in Maine, an overview of what data is available, what does the data show about the current state of the opioid crisis here in Maine, what does it say about how different areas of the state are affected, and what data is missing, or what opportunities do we have to improve some of the data collection efforts across the state. Talk about sources of funding to give the council a sense of the resources that we have within DHHS. What are they? Where do they come from? How do we deploy them? As well as the uses of funding. And then we have provided the council with a slate of what we see as opportunities to perhaps target investments to support our ongoing work. And then as part of the presentation, I did include an appendix of SUD data and trends. If we have time to dig into that, we can, but I put it in the appendix to start because that could be a whole other day of discussion. Any questions on the agenda or the information that we're going to cover? Great. Okay, so just to kick us off, I wanted to share a little bit about the indicators that are currently available across the state. Many around this table might be aware that we partner very closely with the University of Maine to provide and present a monthly overdose report. There are several key indicators that are highlighted in that report. This report is published monthly and it is available on the Maine Drug Data Hub. So that's also a great resource that you can utilize as council members. There are interactive dashboards related to some of these indicators, as well as data visualizations where you can dig in by county level data. So I would just encourage you, if you haven't already, to take a peek at that website. And the link is in your presentation and listed here at the bottom of the screen. So some of the monthly data that we look at are fatal and non-fatal overdoses, the volume by county, We look at overdose reversals, incident patterns of fatal overdoses. What I mean by incident patterns is essentially who's responding. Is it law enforcement? Is it law enforcement and EMS? Is it a bystander? I can say that the 2023 data that we looked at so far, I think 74% of responses to overdoses were both EMS and police responding. Other indicators that we look at are drug categories and combinations that cause death. And then we looked at gender and age composition of fatal overdoses as well, which does trend to be males between the ages of 18 and 50. Some of the other indicators that I wanted to note that we utilize as proxies in terms of how we're doing as a system or pathways to referral and treatment. We have the Maine naloxone distribution initiative report. We use a tiered system of distribution for naloxone across the state. We have tier 1 and tier 2 distributors. There is a report that goes out that gives us information about where naloxone is distributed across the state. We utilize that information to inform our efforts. We also work very closely with the University of Maine to do projections and estimates as it relates to how do we achieve community saturation of naloxone distribution across the state as well. So that's another area that we partner with the University of Maine. Our partners at the CDC are also responsible for syringe services. So there are syringe services reports that go out annually. And I highlight the syringe services reports because they do highlight enrollment in syringe services, which can be a proxy for uptake in terms of individuals who are accessing harm reduction services across the state. So again, just another data point to note. In addition, we have our options liaisons across the state, which I think folks are familiar with, working side by side with law enforcement and communities, providing post-overdose response efforts, making referrals to treatment. So that data is really important because it informs where individuals are coming from, where referrals are coming from, were they homeless? We look at some of the housing stability indicators around individuals and where were they referred to. So that's also another data point that we utilize in addition to prescription drug monitoring data. So the Office of Behavioral Health houses what we refer to as the PNP, which is our prescription drug monitoring program. This is a legislatively statute data repository system that we maintain. It's really our ability to kind of oversee and promote compliance as it relates to the prescription of controlled substances for medication for opioid use disorder. It's also intended to be a tool by which we can educate prescribers across the state in terms of safe prescribing practices. It's a way for us to provide pathways to education for prescribers across the state as well. And we can monitor prescribing practices, which allows us to, we have developed thresholds for what we would call problematic prescribing. So if we are noticing a pattern or a trend for a prescriber, we could potentially refer them to their respective board, or we can refer them to an education pathway that they may access, like the SUD, Substance Use Learning Community, to get more support around prescribing practices. In addition to those indicators, I also wanted to highlight some of the indicators that give us a sense of capacity, access, and unmet need, which we know are critical as we're kind of evaluating the state of how are we doing in terms of providing timely access to care. We have extensive treatment capacity data across different service areas. So whether that's medication for opioid use disorder, we've seen those trends moving in the right direction. That data is included in the appendix of the overview. Our OTPs across the state, which provide methadone, we've been fortunate to be increasing not only the number of OTPs across the state, but the amount of individuals who are enrolled in receiving methadone, residential capacity, and recovery capacity. Again, we also look at and leverage Maine Care claims data. So that's an opportunity for us to look at claims data in terms of individuals, when are they accessing services and what kind of services are they accessing. Also, the to-me data appendix, we have seen a sharp increase in Maine care claims for substance use services, which is exactly what we would like to see. And that, I think, has really been enhanced by the substantial increases in rates for our substance use providers across the state. Between 2020 and 2021, we increased rates by over 70% across major areas of service delivery for SUD. Also wanted to highlight for the council our KeyPro data sets. So KeyPro is kind of our data hub, if you will, both for mental health data and for our SUD data. They do a lot of the clinical authorizations and tracking behind the scenes. So we do have the ability to leverage that KeyPro data to look at things like length of stay and treatment, treatment retention, as well as other indicators. I think we do have an opportunity to leverage that KeyPro data even more, and I'll talk a little bit about that as we get into some of the data gaps and opportunities. But I'll pause there and see if there's any questions.
I just have one question. And you may have said this already, and I apologize if I missed it, but on the Maine Drug Data Hub, is the indicator data you just talked about, is that, or any of the other data, like, is all of that data available on the hub? For
It
example,
is.
the KeyPro and the claims data,
Great
treatment
question.
capacity data.
Yeah, so I can clarify a little bit. That top tranche of bullets as it relates to what's in the Maine monthly overdose report, that is all on the Maine Drug Data Hub. I'm not sure if we post the options report or the naloxone distribution report. Looks like we do. So most of our kind of annual monthly reports are posted there. I don't believe that we post any of the PMP data on the Maine Drug Data Hub. That's more of an internal data evaluation process that we go through. And Maine Care claims data and KeyPro data is also not on the Maine Drug Data Hub. That is something we have to access ourselves through the Office of Behavioral Health or Maine Care.
Okay. So, and if folks wanted more information about the data, they can contact you and see what's publicly available.
Yes, and again, I would encourage folks to go to the Maine Drug Data Hub because there is a wealth of information. But if, for example, the council wanted to specifically dig into like Maine Care claims data, I would have to do some work with the Office of Maine Care to pull that information.
Courtney?
You mentioned prescribing guidance. Has the state of Maine updated our prescribing guidance since the CDC released new guidelines in 2022?
Yes, typically we align all of our guidance with CDC, so I would assume as much, but I can follow up, Courtney, with the PMP team and just make sure that's accurate.
Okay, thank you.
Of course. I saw there was one more question.
Assistant Attorney General. Ask my same question.
Okay, wonderful.
I should let you ask the question.
Again, so a lot of data, but we all know data is just information. We have to turn that information to something that is actionable and continue to use it to kind of inform our work as we go forward. So one of the other questions that was asked was, what is the data telling us about the current state of the opioid crisis? So I wanted to make sure I provided a bit of a visual that summarized some of the data that the Maine data team provides on a monthly basis. And again, if you go to the Maine Drug Data Hub, you can actually see the monthly data for February already for this. The chart here that I'm showing you shows a side-by-side comparison of 2021 to 2022 as it relates to overdose trends in Maine.
Sarah, wait, is the blue 21 and the gray 22?
Correct.
Okay, thank you.
Yes. So you can see, and this kind of breaks down some details related to increases or trends in terms of individuals who might be seen in the emergency department, trends in individuals who might be transported by EMS, numbers of community reversals and fatal overdoses. So in terms of individuals who are seen in the ED, not a significant decrease or increases you can see there. We are seeing a slight increase in those who are not transported by EMS. That's actually what this graph depicts. One of the things that we have noted is that individuals can be reluctant to be transported to EDs by EMS. So that's certainly something that we've been looking at. Community reversals did increase slightly between 2021 and 2022 by about 10%. I would also just note that we would consider this data perhaps slightly underreported, given that this data comes to us from our harm reduction partners. It's likely there are other community reversals that are potentially happening that we're just not aware of. So just something to be thinking about as it relates to community reversals. And as we are all aware, it's deeply unfortunate and really driving our work here today is that our fatal overdoses did increase between 2021 and 2022 by 14%. I did look briefly at where we were trending for this year, the January to February numbers that were posted, and it's looking fairly similar. No significant increases or decreases on either side. We also have to be very cautious about just looking at 2 months of data in terms of any kind of a trend. Obviously, that's something we will continue to look at and monitor closely. And of course, we know what's largely driving overdose fatalities is the illicit drug supply. Over 80% of fatal overdoses being impacted by illicit fentanyl and now xylazine that has made its way into the system as well. So I felt like this was a good proxy to kind of show the current state of where we are in terms of some of the data that we look at on a regular basis. There was also a question as it relates to kind of regional impacts.
Can I ask one quick question,
Yes,
sir?
of course.
So, how does that, the loop, so when you see this data, you great data that's there, do you have a system of reviewing the data and analyzing it? So do you take the data monthly or quarterly and ever, then do the deep dive into why this was an increase or whatever? I just curious as to what, I mean, you have the data's great, you can get on there and do it, but what I don't know is, what do you do with that data?
Yeah, that's another great question. So you'll see in the monthly overdose report that Maine puts out, it's a comprehensive analysis of the data and really digging in more to some of the trends and patterns. I would also say that there are regular tables and groups that meet to do exactly what you're talking about, looking at the trends. Go ahead, Gordon.
We actually look at that every week. There's a team that meets at 10 o'clock Wednesday morning. Actually, they meet at 9, and then I meet with them at 10. And so the first thing we do is look at the previous week's data. I mean, and remember, this is all suspected overdoses and not confirmed until weeks later when the toxicology tests come in. But, and that's about 15 and 20 people, an excellent, 5 or 6 from the university, and the rest from usually from HHS, but we have people from public safety and other places. So I mean, I think it's one of the things we do best, honestly, is look at the data very, very quickly. And again, we probably should have put on this, and I've seen this half a dozen times, it's as much my fault as anybody's, but it would have been nice to put on there the total overdoses. Maybe we've got it in there someplace else, but because now, since 2000, for the last year and a half or so, we've been reporting in the monthly reports the non-fatal overdoses, and that's what you don't see, at least in this graph. There were over 10, well, there were over 9,000 non-fatal overdoses last year. 93% of the overdoses were not fatal. So, but that's, we look at the data every week. I get a weekly report by Friday, and then we wrap all that into a monthly report. So while there was no obvious trend in January, February, by Monday, we would expect to post the March numbers. And when you put those together with January and February, it's promising. It's not right for me to give you the numbers when that report's being prepared and reviewed by half a dozen people. But But I can tell you, it does not show a continuing increase in the number of fatalities, which is really good to see, because remember, November and December were the worst months we'd ever had, and the last week in December was the worst week we've ever had. So it's nice to see that, for whatever reason, and that's where we have to get a lot better at this, but, you know, in January, February, March, it's been more what we would expect. And I don't want to call them normal, because we don't want to normalize, you know, a dozen deaths or, you know, a week, but it's better than it was, and it's not enough trend yet, not long enough period of time to be able to say that it's a trend, but it's sure nice to not see it continuing to go up.
And just a quick reminder that there are people online, there are people watching us online, so when we ask questions, make sure we speak out.
Gordon, what was the number? The non-fatal?
They continue for a long time, since we've been tracking that. It's been about 93% non-fatal and 7% fatal. It was slightly less than 7% fatal last year. And that's been pretty consistent.
I just asked a
Of course.
follow-up. So in the first part of this year, things are looking similar or somewhat better to last year. Is that in terms of the actual, is that in terms of counts or percentages or both? In other words,
Counts, not the percentage. Actually, fatal to non-fatal has not changed. And this is Gordon Smith from the governor's office, the state's director of opioid response, for those watching remotely.
Oh, yeah, flip your name back.
your name,
They can,
You're looking at.
I see, look at that, well, that's so I would remember.
That's how you know who you are today, Gordon.
so the rate of overdoses combined is holding steady-ish
Overall, the overall number. Yeah, I mean, it's just not enough in 3 months to you know, to make a comment about it. I mean, we'll see what the researchers say in the monthly report, which will immediately go on to the data hub and be public on Monday. So Monday's the first day that the public would know that actually what the fatality numbers were for the first 3 months. And I wouldn't expect a big splash about it, because we're not gonna, I mean, we really want to see that trend continue. And as you know, to us, this is one data point. There's an awful lot of other things. We understand that the media and the public really are focused on fatality. I mean, I understand it. It's not just one person, that's their family, it's a community, it's a tragedy. But we know from our work with the other states too, that we're all, we're discouraged when we're doing so many things that we're supposed to be doing, and the number continues to go up for reasons that really are beyond our control for the most part. And so again, we're going to continue, we're not going to depress that number, we're going to continue to put it out there. But just as we now talk about also the thousands of people who were successfully reversed and are alive and are connecting with our options liaisons, you know, we're not going to, this isn't the, it's important. It's important to keep people alive. I don't mean to suggest it isn't. But it's also important to prevent people from starting that road in the first place, to support people in their early recovery, and to have treatment available for people when they need it. So it's, again, to look at it holistically, this is one important piece. It gets a lot of attention, but it's not the only thing that's important in this world. Sorry to interrupt your flow.
No, it's great, thank you, Gordon.
I've just got a question for Gordon. Do you know the percentage of non-fatal overdoses that received naloxone, that were reversed by naloxone?
I believe that in the monthly report, actually in the weekly report, there's certain things we track, which, and one of them is whether there was a script for naloxone, whether there was naloxone present, was it used, and if so, by a bystander, by law enforcement, by EMS. We also look at whether a person has been incarcerated within the previous 30 days, were they in a hospital within the previous 30 days, were they experiencing homelessness, a whole bunch of things that we track, and we look at those Wednesdays. It's pretty fresh data. So I believe that in those monthly reports, we definitely have it for the fatal cases. But not surprisingly, as Director Squirrel has said, the non-fatal cases are underreported. We may never hear about them, so it's partial data. But I think that there's some things in that report that also talk about that. We track on naloxone distribution fairly well. It's complicated.
Yeah, and to follow up, and again, I would encourage you to go on the website to access the report, and it does distinctly show community reversals with naloxone, law enforcement reversals with naloxone. For example, January to February year to date, there were 376 community reversals with naloxone. So you can get that data
Right.
on that report.
How many were for law enforcement?
According to this, law enforcement, 52.
Thank you.
Okay, I'm going to move us ahead. We can always come back to any of these data points again, and I think the council would benefit from digging into some of the reports a little bit as well. We were asked to talk a little bit about kind of regional impact and effects, which I think are really important. One of the things I really like about the Maine Drug Data Hub is the interactive nature of some of the dashboards, so you can really dig in by county, you can look at trends. So there's several indicators that provide that county level data. So we can look at the number, percent, and rate of overdose deaths by county. We can look at overdose deaths by selected substance. What I would say though is that if you're asking the question of, what are kind of the regional effects, if you will, that this is a statewide problem and all counties are impacted. And when we look at the data, what we see is that most counties are within 1% to 2% of their census proportion in terms of number of overdose deaths. So that's just, I think, important to keep in mind, and all of that data is listed on the Maine Drug Data Hub and on that report. I think there were a couple regional pieces that I did want to highlight, a couple of counties that have historically had slightly higher rates of overdose deaths across the state. Penobscot County is one that I would just note. We know that Penobscot is also a hub for medical services. People travel there quite a bit. There's a high population of individuals experiencing homelessness, and it's right on the I-95 corridor. Cumberland County has historically sometimes had higher rates. They actually had a brief period where they went down, I noticed today, but again, that's a high density population area. And then Washington County, unfortunately, has typically demonstrated slightly higher rates, and we do generally acknowledge that there's just a lack of access to services in Washington County. So again, as we're thinking about targeting resources, this is how we can use some of that regional data to really make sure that we're addressing the unmet need in some of our communities across the state of Maine. So there was a great question related to data gaps and opportunities. Essentially, what data is missing, what do we need, what can we do better in terms of our data collection? These are questions we ask ourselves at the Office of Behavioral Health all the time. One of the areas that we really see as a gap is our ability to monitor kind of longitudinal data of individuals across their lifespan as they access different levels of services across the continuum of care, whether that's prevention, harm reduction, recovery services and supports, or treatment supports. What we have is a lot of point-in-time data of individual moments for folks. So they might have accessed services here, they might have been in a recovery residence at this point, but how do we link that together to really see what that looks like for an individual, and where are the opportunities by which we can improve access to care, or what did we miss for someone along the way that would have been helpful to them at that time. I would also say that we have opportunities to improve our data and analysis regarding timely access to substance use treatment and care. So I mentioned the KeyPro data a little bit earlier as it relates to length of stay. One of the areas I think that we could really lean into, which will require some work with providers, is really understanding at the point that someone was referred or at the point that someone was on the door for SUD residential treatment, how long did it take for them to access that care? Were they put on a wait list? Did they have to wait 7 days? Did they have to wait 15 days? Did they have to wait 30 days? We actually do a bit better of a job of this on the mental health side of things, largely driven by the consent decree because we are required to. So I do think we have an opportunity, and we've been talking internally at OBH, working with KeyPro and providers, creating some kind of a referral process system by which we can track when individuals are trying to access care, how long it takes them to access that care. That could give us really good information about gaps in the system and what aspects of treatment, recovery, other services that we really should be focusing on. Again, we use that data a lot in terms of mental health, in terms of timely access to care, to really kind of drive where we might want to invest resources to really bolster capacity across the state. We do have 2 projects I wanted to highlight for the group that get at the first bullet in terms of how do we better longitudinally monitor individuals across lifespan. The team from Maine, in addition to working with us and CDC and Maine ENS, we have some funding for OD2A federal grant, and we'll be looking at, we call the Non-Fatal Patient Journey Project. It's really going to allow us to pull some of these data sets together to look at patterns and really understand the trajectory for individuals as they're trying to access different levels of service across the continuum. That work is just getting off the ground, so we'll be sure to update the council as we progress. We are also within OBH, we have a Harold Rogers grant, which is a federal grant, and we'll be implementing the SUD Master Data Repository Project. This is going to allow us to leverage the data from the PMP, the Prescription Drug Monitoring Program, kind of match that with some of our other external data, EMS data, emergency department, inpatient treatment, outpatient treatment, again, to really get a sense of someone's kind of pathway through these services, and that should allow us to better understand what were those missed opportunities to coordinate care for individuals more effectively. So those were a couple projects I wanted to highlight for the council, just for awareness, and I think a couple of the areas where we have opportunities to strengthen our data collection to inform some of the work that we're doing. So I'm going to be shifting now into a bit of a review as it relates to sources of funding. That was one of the asks of the council in terms of the agenda. So I'll pull up this next slide here, and that will take a moment to orient you to this. So we wanted to, as simply as possible, provide the council with information on the sources of funding for substance use services and treatment through the Office of Behavioral Health. So what this demonstrates on the left-hand side, we have state fiscal years. So this is demonstrating 2018 up to 2023 in terms of the budgets. And then you'll see the bars, if you will, which are color-coded, represent the source of funds. So for example, the dark blue on the left is our SUD general fund. And you can see that we've seen fairly stable trend as it relates to our SUD general fund. Between 2018 and 2019, there was a bit of a jump. You can see our federal block grant funds across kind of the years, the federal special grants, in addition to our funds for Healthy Maine, the opioid prevention and treatment fund, and then we have another category. I'm going to be going into a bit more detail about each of these, but I did want you to kind of see the overview. One thing I would just note is that we have realized some one-time special federal grants over the past couple of years related to the pandemic and opioid response that will be sunsetting in state fiscal year 24 and So we currently do have a budget initiative for 24 and 25 that's currently being reflected on by the legislature. That's about $3.6 million annually that we have requested for our FY24, FY25 budget. And you'll also notice in FY23, it appears, because this is budget-based, that there were substantial increases in federal block grants and federal special grants. That's true to some extent, but what this also shows is that some of our federal block grants are 2-year grants, 3-year grants, 4-year grants. And sometimes we don't get the federal funds until months after the award. We tend to, there's delayed implementation, as you can imagine. So some of those funds get pushed into future fiscal years, which is also why FY23 looks a little bit bigger. So just wanted to give you all a sense of that.
So point of clarification, you said there's about 3.6 million in COVID funds that will disappear next year?
No, we have, I would have to follow up with the exact amounts. It's our CURSA and ARPA federal grants that are sunsetting in 24 and 25. I can follow up with the direct amounts, but the amount that we requested for our 24-25 budget initiative was annually $3.6 million.
Okay, that's requested. Thank you.
Of course.
Am I right, Director Squirrel, that money, the 3.6 annually in the proposed budget did not get in the baseline budget that was passed, but it's in this second budget?
Yes, I believe
Correct.
it is in the Part 2 budget.
Yeah.
That's accurate, Gordon. Thank you.
Disappointing to say that, but when you think about it, it's new spending, so from the budget standpoint, so it's not surprising that it didn't get in the baseline budget. You'll remember that they passed as an emergency, then adjourned, and now they're working on a bipartisan supplemental budget, I guess we call it, or
And the 3.6 is in the one that they're currently
working on.
working on.
And maybe you already said this, maybe I missed it, but what is that for? What is the $3.6 million for?
I'm going to turn that one back to Director Squirrel.
Yes, so we have expanded our service delivery across the continuum, and in order to maintain our current level of service delivery for SCD, whether that's recovery, whether that's MOUD in jails, the $3.6 million will allow us to continue our current efforts and take into consideration some of the sunsetting of those federal grants.
Okay, thank you.
Sarah, you might be able to, I'm sorry, I'm talking a lot with my mask on here. Can you speak a little bit to the workforce, what you're seeing with workforce and how it fits in? And maybe you're going to in your presentation, but when we talk about capacity and especially wait lists and access, what are you seeing in that space?
Yeah, I mean, I think we would all agree that workforce is kind of foundational to some of the challenges that we've been having in terms of, really advancing our capacity in the way that we would like. But this is why we've taken some very targeted approaches to supporting our providers. One, for example, is, one of the hallmarks of our proposal for the budget for this year is substantial continued behavioral health rate increases in addition to cost of living increases for our providers across the state. I think it's $46 million in COLA increases to support our direct care staff. In addition to that, we've also implemented things like the Catalyst RFA. And the Catalyst RFA was really meant to be paired with the Capital RFA because we want to increase our substance use residential treatment, but we need people to do that. So the Catalyst RFA is available to providers to use for staffing ramp up, which we know they need to really bring people into the field and retain them. So I think workforce is key. We have large amounts of workforce development activities in place in terms of certifications and licensures and pathways to employment and career ladders. But Maine, like all other states, particularly in New England, it's a real problem for us. But that's why you see us putting forward substantial increases to support our direct care workers and trying to create flexible pathways of funding for providers to be able to recruit and retain these staff.
Definitely. And I think sort of just the expansion of recovery services and expanding the group of people that can work with folks versus the traditional professional folks, that number's shrinking, unfortunately, probably around the country, but especially in Maine. So it's nice to see the expansion of recovery coaches in that group.
Yes, couldn't agree more.
Thank you.
Okay, this is just a brief description of each of those funding sources, and then I'm going to go a little bit into the details of what's really in each of those slices of the pie that we just looked at, and I think the overall total there was about $56 million. So we're all familiar with the general fund. This is the primary operating fund of Maine state government. We have two general fund sources. One is our SUD general fund, which is kind of the basis for many of our treatment services, et cetera. And then we have our DEEP program, and this is our program that provides services to adults and teens who are involved in alcohol or drug-related motor vehicle incidents. So if they get referred to the DEEP program, they can, they'll have an evaluation, they'll get connected to the services that they need, and a process by which they can go to get their license back. We also have our federal block grants. These are non-competitive annual grants that the state of Maine receives based on a funding formula that the federal government has. I think Gordon and I would both agree that we think the funding formula is flawed and that Maine gets a bit less than we would hope for, but they are annual or two-year grants that we can count on. Some of our federal block grants were enhanced this year and supplemented with one-time COBA grants and the CURSA and ARPA grants that I know that will be sunsetting. We also have federal special grants, and these are time-limited competitive grants. So we have to compete for these on an annual or every other year basis. This includes our state opioid response grant, which is SOAR, our overdose to action grant, which is OD2A, and our Harold Rogers grant that I noted. And these grants can shift and change depending on what policy is being, discussed at the federal level. For example, we just got renewal for application for our OD2A grant, which funds a lot of our data and evaluation work. And there was a policy decision made at the federal level to not fund PMP programs anymore. So that caused us to have to step back and really look at other ways in which we can fund the prescription drug monitoring program, which we know is so critical. So all to say that we are constantly braiding funds together to make sure that we can continue to provide all of the services and keep our programs running. I would also note that we receive funds through the Fund for Healthy Maine, which folks around this table are aware was related to the tobacco settlements. This is typically funded Prevention and Treatment Fund. And I did want to highlight the Opioid Prevention and Treatment Fund. These are revenues that come in from fees on manufacturers in the state that sell, deliver, or distribute opioid medications. We've really leveraged this to support new initiatives, pilot initiatives, and really focused on prevention work this year. And I'm able to share a little bit of some of those projects that are being funded through the Opioid Prevention and Treatment Fund a little bit later in the presentation. So this is taking a snapshot of FY23 just to give you a sense. I know if I were sitting in your chairs, I'd want to know what percentages of funding are going where and to what buckets of our opioid response. So this is really just designed to give you kind of a snapshot of where those funds are being allocated. You can see the biggest piece of the pie is treatment, which is about 46%. I'll be going through a little bit of a deeper dive into each of these slices. Harm reduction is about $7 million, which is 12%. Recovery, $6 million, which is about 11%. The services and supports that we provide for justice-involved individuals is about $5.5 million, 10%. Prevention is about $4 million, 7%. Data and monitoring, the other category, which is essentially contracted staff for the department, and workforce and education, as well as this chart. What is not in this chart is the Maine Care funding that is leveraged for a lot of the service provision. So we did outreach to Maine Care to get the number in terms of what annual funding through Maine Care through billing is going on an annual basis to substance use services. So Maine Care is working on that, and we'll follow up with you all with that information. So I think that's important to kind of, this is just a piece of the OBH funding that is supporting our SUD work, but obviously Maine Care is a really big part of the funding for SUD services across the state. In addition, our partners at CDC also receive some direct federal funding to support opioid prevention work, and I'll be sharing a little bit more in this presentation about what they receive as well.
Sorry, looking at this pie chart, the workforce and education looks pretty small. Is there money available for workforce and education that people are choosing not to access? Or is it that there's not very much available?
Yeah, that's a great question. I don't think it's about lack of access. I think it's about the state, trying to leverage as much funds as we can to support workforce development. That's something that's not, an area of treatment. We don't leverage Maine Care to support workforce development. So we do have some sources of funding to support that, but many of the federal grants and other sources of funding have not been focused on workforce as much as other areas.
So most of the grants are pretty specific on what you can use the funding for.
Very much so.
The other thing I'd add there, a lot of the workforce and education fees are in other departments. They're not they're not in HHS, there's a lot in the Department of Labor.
Correct.
There's a lot in the community college system. There's some in the Department of Education. So this is simply the 1.3 million that flows through the Office of Behavioral Health. There's a lot more if you saw all the activities within all the 15 departments of state government.
And am I making a big leap, but my guess is, does a majority of that go to like outside of contracts, like ad care or whatever, to provide continuing education to people and to, or is this separate from the contract we have?
No, I'm not qualified to answer it. There's programs now with the Department of Labor that provide direct assistance to individuals for retraining, for training in healthcare. We have a full-time healthcare workforce person in the commissioner's office. Yeah, and so she works closely with the Department of Labor. So there's a lot of pieces there in terms of, and fortunately now there's quite a bit of intersection with the SUD piece. For instance, there's a employer summit in May, expecting 500 people there, and we are doing a whole panel on recovery, people in recovery being available to work, and we put that panel together with them. There's people on the panel that you all know, so we're recognizing that, fortunately, that there's a great potential there to match people in recovery who have been out of the workforce for a period of time with available jobs.
Thank you, Gordon. And to that question as well, just looking at the detail within the workforce development and education, it does include like the funding for the SUD learning community, which has been so critical to our work. So that is in there as well.
For me, the major concern is that it's great we're increasing services, but I worry who's going to do the work. So it's nice to have the funding to say we're increasing beds or we're increasing detox, but it really is that are people going into this field, and how can we encourage that particular? Putting people in recovery to work all over is great, but there really is I think a concern in regards to who's going into the field and how will we manage an increase in services without a workforce that's paid reasonably. As a woman who's retired from here. Thank you, sorry.
No, thank you. Great questions. Okay, so I'll just walk us through a little bit of what's in the slices of the pie, which I thought would be helpful for this group. starting with harm reduction, and there are funds that actually flow through the Office of Behavioral Health, and then we pass them through to CDC. So harm reduction is a good example of this. So CDC operates the syringe services programs across the state. So that funding comes through OBH, and then we push that to CDC. Also, our options, liaisons, and media campaign are within the harm reduction category, in addition to our naloxone distribution efforts across the state. The biggest slice of the pie was the treatment, so I wanted to talk a little bit about some of those treatment pieces that are funded by the Office of Behavioral Health, with the caveat that obviously we were leveraging Maine Care to also fund much of the service provision for SUD services across the state. The Office of Behavioral Health also supports providers for funding for services for uninsured and underinsured, so that can be a lot of the work that we do. So outpatient services, opioid health homes, which are operated by OMS, are also, categorized within this area. Our residential treatment programs and medically supervised withdrawal programs, our opioid treatment programs, our OTPs, and then our medication-assisted treatment and office-based opioid treatment. And this is where the funding for the Capital and Catalyst RFAs came from as well. In terms of recovery, there's some great slides in the data appendices just about the incredible work that has been happening to really expand recovery services across the state. Recovery community centers, certified recovery residences, the recovery coaches, and all of that is trending in the right direction. And I know a lot of people around this table have been incredibly influential in advancing that work, so thank you. So our recovery includes recovery coaches in emergency departments, our recovery community centers, recovery residences. We're very excited to be launching some work under Gordon's leadership related to recovery-friendly workplaces, in addition to our MAR certification. And MAR is the Maine Association of Recovery Residences. They really kind of oversee and provide kind of the ethical and safety standards for our recovery residences. They certify those residences to make sure there's a high level and high quality of care. In addition to that,
Sorry, just to back up a little bit to the treatment allocation. What's the difference between the OHH and the medication-assisted treatment and office-based opioid treatment?
Great question. I asked the same question to Catherine earlier, actually. So opioid health homes is a separate provision of service delivery that's offered by, it's overseen by the Office of Maine Care Services, and it's a team-based approach. So you have access to a whole host of services, medical services, SUD services, peer services. It's kind of a holistic approach. MAT and office-based opioid treatment, which we refer to as OBOT, are essentially behavioral health or primary care providers that are providing MAT services. So they really, those two are kind of one and the same, which was the question I asked Catherine earlier. So, Catherine, if there's anything to add to that?
Thank you.
Yes, of course. And of course, wanted to highlight the work that we are doing as it relates to our criminal justice services and services to support those who are criminal justice involved, funding to support our treatment and recovery courts across the state, and our Maine pretrial services, which is essentially our court diversion program here in Maine for individuals who are being charged with a crime, have a substance use issue, they can go to the treatment and recovery courts. We work with Maine pretrial, we can have case management services, get referred to treatment as appropriate, and then of course our funding to support MOUD in our jails, as well as OTP collaboration in terms of methadone. Maine has been touted nationally in terms of the work that we have done to provide medication for opioid use disorder in jails across the state. I think we can also do more. I think we need to really ensure that we are supporting our counties and our jails in terms of providing MOUD in those settings. So you'll see that one of our recommendations for the council to consider is specifically around this area. And how do we continue to provide adequate resources to support access to MOUD in our jail settings across the state.
I just ask just a quick question. That MOUD in jail settings, is that through a grant to the counties, or is that directly, is that a contract that the OVH goes in and does it, or how does it work?
It's a grant directly to the counties themselves.
So the counties reallocate it to provide those services.
And those are the jail contracts.
Yes.
The grants, but contracts. And we had a meeting on it this morning, eight, we have contracts with 8 jails, so it's not every jail. And when we get to the slide on, well, here's some gaps that, yeah, be important to help and for the, I don't want to give you the details now and interrupt the director, but there's a lot to think about there in terms of helping, how we can help the county, because of the, we require them to have a program, and when there's such a shortage of staff, and this isn't easy, and it's complicated, but I'm really proud that they're all trying, sometimes with very limited resources.
Miles, and then
So is the funding going to both the OTP and to the jail for these programs? Or is it funding the jail who?
It's going to the
Funds the
jail, who
OTP.
can then partner with an OTP to provide services within the jail.
In the past, I was Catherine's the expert on this, actually. There was a time when we were paying directly the provider of the service. And through Catherine's efforts, we kind of made those contracts more uniform, and now the money goes right to the jail. So we don't.
so the jail is purchasing medication with the grant dollar?
That could be one of the things they're doing with it. Would they be using our grant dollars to purchase medication? That's certainly happening in the
Sometimes,
pilot,
yeah.
in the Somerset County Jail.
Yeah.
It's actually probably not the cost of medication if they're doing buprenorphine.
Mhm.
That's actually the big cost. It's really everything else. It's the
Yes.
cost of the provider, except, whereas in the cost of in the project where we're supporting Sublocade, it is the cost of the product.
And you can't bill Maine Care for people that are incarcerated. So even if an outside provider comes in, that provider cannot bill Maine Care services because the person they're providing services for is incarcerated.
It's always been, until recently, that you couldn't, that Medicaid federally, under federal edict, would not reimburse, would not cover people incarcerated. However, how many months ago? A short time ago, California was granted the first waiver to cover the cost of medication and treatment within 90 days of release. So that's a big deal.
Mhm.
And so naturally, everybody's being encouraged to do that. Now, these amendments to state plans and waivers are a big, big lift. But believe me, we're working on it because that would be a considerable cost savings to the state.
That was actually what I was gonna say. I was gonna ask the state of Maine is planning or has already submitted a section 1115 waiver for incarcerated people.
We have not, let me make clear, we have not. But they're looking at it. We want really Director Probert to address how complicated that all is, because we have an existing 1115 waiver. And it appears that amending our existing waiver to include that would be way easier than submitting a new waiver. So, yeah, we're gonna be right on it, but it's not done.
The other thing I will say on this note is that in my other I also serve on the Augusta City Council, and we're going through our budget process right now, and the county came to visit us this week, about their budget. And what, County Commissioner Pat Crockett let us know in that meeting was that Kennebec County is currently spending $635,000 a year, on this program. They are gonna be using their opiate settlement money to fund a portion. She was unable to give me a particular number, but they are planning to use their opiate settlement money to do this project in the Kennebec County Jail. So I would just, before we decide to use the state's opiate settlement money, I would want to ensure that other pots of money are not already being used, or this waiver is not available to us, because there's a limited amount of money for everybody. But also in that role, totally understand that it is really hard to raise the money to pay for incarcerated individuals' healthcare through city taxes, because city taxes are restraining, and we have currently an 11% budget increase in front of me at the city council. So, and all that money to pay for incarcerated individuals' healthcare comes up through property tax. That was my rec for today. Thank you.
It's a great point, Courtney, and something we've been thinking about too is how do we make sure our efforts here are complementary to the funding that's directly available at the county level as well.
I'm the provider for MOUD at the Androscoggin County Jail, so I can give you just a little idea. We're contracted by the jail to provide the services. We have a set amount. That we have to consider the cost of the medicine, so the medicine comes out of that payment. My salary, the substance use disorder counselor salary. What it doesn't include is the cost to the jail for their correction officers to assist with delivering the medication, which is probably right now our biggest limit. That they don't have the personnel to do it.
Can I just clarify, do you mean like driving pallets of medicine to the jail?
No, when the medicine is given to the patient, that's monitored by the correctional officers to decrease the risk of diversion. And that takes quite a bit of time.
Can I ask you just a simple question about that? Is it in the Androscoggin County Jail, has it been normalized so that that buprenorphine, if that's what you're using, is dispensed at the same time everybody else's medication is dispensed, or is it a different process?
It's a different process, and I talked about to the medical team about that today. And the reason for that is because of the funding, we can only have, right now, we probably have less than half of the inmates that have requested MOUD on it because of lack of funding. And so there is a big problem with diversion. We've had to address it a few times since I started in September.
That's more complicated than we should get into right
Yeah,
now.
but just so you have an idea of where that money goes to when the jail does that.
So,
I was just gonna ask, is it the nurses that monitor or the correctional officers?
The nurses give the medication and the correctional officers monitor.
Is there a time period? Is there an estimated time period of how long it takes to monitor for each medication? I know methadone is probably much quicker. But
Yeah, they have to wait for it to dissolve, so it takes about 15.
Diversion is a whole other subject.
Yeah.
Thank you all for that. Thank you.
just to follow, it sounds like, I think you're answering the question that I've been sitting on, which is, Gordon, I think you said that later on we'll talk about the fact that there's funding for this in some of the county jails, but not all of them, so there's a gap. But it sounds like, Dr. Vinsel, you're also identifying that even in those places where there is funding, there's a gap. So we're not meeting the need in the places where there's already this service being provided. And then there's places where there's no service provided.
This question does not need to be answered, but I feel like I have to ask it. Why are there so many people who are incarcerated that need MOD services?
It is a huge question.
Well, I have a second, similar. Why is it that if our obligation constitutionally is to provide care to individuals in the jails, how could it be that we're only, that a jail that's trying, that has a very capable physician working with them, how is it possible that only half of the people who are eligible and asking for medication for their illness are getting it? Would we do that if they were diabetics? We'd say, well, this is costing too much money, we were only gonna give insulin to half of them. So,
It is. It all leads to stigma, and it leads to lack of funding, lack of understanding it, a lack of what we do in the United States, but what we promote. So, thank you all for that, and your parents.
Great discussion, thank you.
Can I just ask two just some short follow-up questions? The treatment and recovery courts line item, is that the same funding mechanism that we just talked about, where it's like sort of a grant to the county?
We're actually shifting it to grant directly with Maine Pretrial Services to make it a little bit more coordinated for the providers. So it's a slightly different payment model.
And then on the MOU, and maybe this is in a later slide or elsewhere, there's the last line item about the jail settings include sort of wraparound services for folks who are leaving jail and like re-entry into community, kind of warm handoff.
No, at the point that an individual might be leaving a correctional facility, I think there are other services and supports that might pick up then. For example, I would note our intensive case managers. That's our team of folks from the Office of Behavioral Health that are actually embedded within the jails that provide kind of case management services, referrals to community treatment. So at the point that an individual is transitioning back to the community, there are other community-based or jail-based services that can pick up and help with that transition.
And I also add, we're also looking to expand care services to actually support that as well.
Can everyone hear Catherine?
remember too, that as soon as the person is out, their main care is reinstated. Now there's work done during the period of incarceration so that happens, when they walk out the door. So that's very helpful. At the Department of Corrections, they have a contract with a provider that all over the state matches that person being released from the Department of Corrections to a medication provider in the community that they're being released to. It's a little easier for the Department of Corrections to do that because they have the person a longer period of time. They've got time to do that. But I mean, that's obviously the gold standard, is that, we wouldn't honestly be pushing medication to treat people who are incarcerated if they're not going to be able to continue that medication with a community provider, because they'd be at really high risk of death if their medication is cut off.
So it sounds like there's a connection that the person is enabled to qualify for Maine Care the minute they walk out the door, but at least at the county level, they may not be necessarily connected with a provider.
Well, the goal is that they are, and the problem is that the 16 different programs, there aren't 16 different medication providers, but there's quite a few different ones. They contract that out frequently every year to the lowest bidder. So we're working on it. We have a quarterly meeting with the jails now. The next one is on Tuesday morning, I think. And it's really going quite well when you consider, number one, the pandemic, and number two, severe workforce shortages. So we're asking people to do the right thing here at a time when they barely have enough staff to do the public safety function. of having the person in there. But, and that's why I say that, you know, we're spending this time on it, it's time well spent, because these are people in our custody. They're the governors, I would say, in executive order too, they're our highest priority, because they are at great risk. They're already caught up in the criminal justice system, they have a substance use disorder. We're doing, and so people are really trying, but it's, and that's why it's a gap, because it costs a lot. And while we can say, look, and I have some of these really difficult conversations, I keep looking at Betsy, I kind of see her as representing the county money people. It's not, with the people in the county jail, it's the county's responsibility, constitutional responsibility to provide the medical care for those. But we need to step in and help them in every possible way to do that. And what's remarkable is that as we struggle to do this, we're leading the country in the percentage of our incarcerated individuals who are on medication for substance use disorder. And we should be very proud of that.
And just going back to the overdose data, is that able to be disaggregated to identify, like, do we have a sense of folks leaving jail, how much, what proportion they make up those sort of overdoses?
Yeah, absolutely right too with T. Last year, it was 1.7% of our fatalities, which I think is a really good number. There was a time when everybody thought that almost everybody that died had just come out of jail. This year so far, it's 2.4%, which our mathematicians at the university tell us is not a statistically different number yet. So, and a lot of this work's been done by the overdose review panel, by the way, that we'll talk about someday, the work that panel does. But that's why I say it's about backpacks in York County, you know, that are given to every person that leaves the jail with everything from fentanyl test strips to naloxone to, you know, other harm reduction things. So there's a lot of good work being done, and it's beginning to show in the numbers.
Great, thank you. Okay, just moving us along, some of the data and monitoring activities I already mentioned in terms of the prescription drug monitoring program, the Maine Drug Data Hub. Also just want to highlight our overdose surveillance and spike alert coordination work. There's a federal program called ODMAP that gives us information as it relates to overdoses. How do we use that information to potentially alert the community and the public if there are spikes across the state? Currently, CDC is actually doing a very small scale pilot around this. And right now, the Office of Behavioral Health, CDC, Public Safety, EMS, Gordon, we are all working collectively to develop what we refer to as an OSAP, which is an overdose surveillance action plan. So really we're looking at how do we leverage all of these different data sets? What does the data tell us? How do we translate that data into information at the community level in a timely way that can be useful and helpful to alert communities if there is a spike? And then finally, what are we asking individuals to do with that information? So that is work that is underway. We're currently working on developing an implementation plan for that. But that's some exciting work that we're also, I think, leading nationally. We asked our national partners for some consultation around developing this, and they said, well, we'll wait to see what Maine does, and then we'll take your lead. So again, some great work that's happening there. Also, can't underscore and highlight enough prevention. I think we would all agree that we have a key opportunity to go upstream and intervene earlier for our younger Mainers. There is a lot of work that is happening in the prevention realm. As I mentioned, some of the funds come through the Office of Behavioral Health. CDC also has some direct funding that they use. What's reflected here is some of the funding that comes through OBH that we then provide to CDC. Some of the work that I would highlight is currently implementing Youth Expert in some of our school-based health centers across the state. CDC has done a tremendous job of expanding school-based health centers across the state, which I spend a lot of time doing school-based mental health work in Vermont. And if there's one place where we can access and see youth and children, it's in schools. So bringing the services to them is so critical and key. And some of the data we looked at over the past couple of years, over 75% of visits to school-based health centers are for mental health or substance use services. Youth are also much more comfortable accessing services in a normalized setting like their schools. So again, I just can't underscore enough what an opportunity we have to really embed more services in our schools and support the Department of Education.
Can I ask a question about the school-based centers? Do you have any numbers of how many schools hire a substance abuse counselor in the building?
That is a great question. I would have to follow up with the Department of Education to get that information.
It was my favorite job ever. I served as substance counselor within a school system, and I can tell you the rewards that, just curious, and at the time, there was a few schools, probably a dozen in the state that hired them. And I was wondering if there was any question on how many schools in Maine today hire substance abuse counselors that are based within their school.
Yes, I can follow up with our partners at the Department of Education on that.
What's your question?
Also, is there, I don't know if you can find out the number of actual schools that the CDC is working with across the state of Maine? How many schools are actually receiving these programs?
Yeah, we do have a map of the school-based health centers in particular, so I could follow up with some information as it relates to that. There are many other areas of service delivery that are happening. All schools approach it a little bit differently, I guess I would say. Some schools, for example, contract directly with a behavioral health provider who comes in and provides substance use, mental health services. Some schools have established school-based health centers. Some schools hire their own internal folks, to the chair's comment related to LEDCs. So it's a little bit different everywhere, but we can get you some information as it relates to the school-based health centers in particular.
And instead, Miles, you're asking about the prevention program pilot. Each of the main prevention partners in those 9 public health districts, Liz knows about this because she's one of them, have to, by May 1st, fast approaching, report back to the CDC, if the deadline was extended, on the 3 middle schools. They were given an additional $1 million collectively, $100,000 each, to work with 3 middle schools in that district and on an evidence-based program that involved both community and school. We're looking at that very carefully through the Children's Cabinet, because remember the governor announced in her second inaugural speech that she was committed to having a prevention program in every school, 400 schools, and every community, hopefully together by the end of her second term. And it will take that long, but with the right infrastructure, it can be done. So we'll be able to tell you by Monday, Miles, who the 3 middle schools are that's been chosen by, I think it's ACAP, who's the prevention partner in Aroostook County.
Thank you, Board.
And can I just mention, I think there is prevention curriculum that is being required to be in those, 3 middle schools in a public health district. But there is a ton of work that the Maine Prevention Network partners, who are prevention partners, do with schools to do systems level change. That is really about working with families, working with teachers, doing training, supporting nurses, training of staff for how to improve their skills for working with young people who are at risk for substance use and doing the work before they're at risk, right? So I think there's a curriculum, which is one element, but then there's this whole scale prevention effort that prevention partners are working on with many, many, many school districts beyond those 3 middle schools. So I think
So it's happening all around the state?
all around the state
No, all right.
through the prevention providers. So there's 9 lead organizations that are receiving prevention funds from Maine CDC, and then those funds are then distributed to I'm not sure what the current number is actually of subcontracted, but I think it's somewhere around 20 organizations that then do the work with individual communities, or a smaller sphere of communities. And then there's also other communities that receive federal funds to do some of this work, and those folks work kind of in concert to do their work more efficiently and effectively.
So has this been happening for a while, or this is a new pilot
Well,
program? Or
so prevention work in this model of the state funding local prevention has been happening for a long time. It was originally under the Maine, Healthy Maine Partnerships, which then was sort of changed and shifted during the LePage administration and was called Maine Prevention Services, and now it's in a different model called Maine Prevention Network. But there are many organizations that remain the same who have been funded to do prevention work and have deep relationships and deep work that they've been doing. And I'll just mention while I'm talking, I think that pie chart that we look at real quickly about like total allocation, if we add in Maine Care spending for treatment, my guess is that this prevention pie reduces to somewhere around 2 to 1%. So you will hear this from me a lot about the fact that this prevention stuff is not just kids who've never been touched by opioids, right? Like this money is for folks who've been impacted by opioids in their life. This is also for young people who've been deeply touched by opioids directly and also through their community. So you will hear me talk a lot about the fact that this pie makes me sad.
It's way too small.
It makes me sad.
Can I just add, Sarah, when you were talking, and Liz, your point about sort of who's doing the work, I think the who's doing the work is really important to us. So the breakdown you just listed, is it a private provider, is it a school? Because all things aren't equal. Some schools I know during the pandemic would reach out to my organization and have no resources. Others have more resources because of their size or the capacity financially in a town, a municipality. So I think, and the bigger issue or my worry is reinventing the wheel. So people don't find that the mental health world is fast enough, so they hire their own. And then we have a parallel system going on. So I think this information is really important, especially in prevention. And I know there was a great system, and now it's hopefully making a comeback because it's really important. It's sort of at the heart of the matter when we think about upstream. But any information about sort of the who and how it's broken down, I think is really important to us.
I agree. I think we're asking all the right questions, and it's a great discussion around prevention. And I think the Department of Education could also share a bit of insight as it relates to the different ways in which school-based mental health and substance use services are being provided. I do think this is also an opportunity not to forget or to remind ourselves about the co-occurring nature of this and primary prevention as it relates to, well, early intervention, I think, is prevention. And then even going further upstream around issues related to developmental trauma and our 0 to 5 or 0 to 8 populations in our elementary schools. So we can follow up with DOE and try to get a better sense of what that looks like.
That's great. Let me just take 1 second to remind the council that 3% of the recovery fund is required to be dedicated to the grant program specifically for schools statewide, for opioid abatement activities, generally related to sort of special education services or programs. But you can read the MOU and sort of read through what the priorities and focus of that grant program is meant to be. It may not, in your minds, match the way I've described it, but in general, just a reminder. And that's a floor. The council can make a decision to spend additional monies for the same thing or for other school-based things.
So the question I have about the 3%, so the 3% of this money that needs to be spent in school is part of our money or part of money that has gone to them to determine? So this is separate from their money. So 3% of the money that this council has, 3% of it needs to focus within the school districts.
So
On special education.
And do they define what special education is?
Yeah, so to answer the questions, it's 3% out of the 50%, which is the recovery fund. Recovery fund is comprised of 50% of the settlement money.
Right.
3% of that is dedicated to this grant program. And, the criteria for the grant program are described in the MOU. I can't necessarily, I don't think I can describe it better than that.
Okay, I can.
I mean, it could be, something that's broad enough that could encompass other things, but it would be an application process. And, there would be, schools would have to submit applications to that. But that doesn't, they could apply to the Recovery Council, they could apply to their county, they could apply to their city or town that got money. They're not limited to it. This is just an opportunity. And the council can take the opportunity to expand that applications.
Great, thank you. As I noted, Maine CDC also directly receives additional funding. I think the total for this was about $1.2 million here. Again, these are programs that CDC oversees, so if you have follow-up questions related to any of these, I'm happy to circle back with CDC so they can provide more information. We did just want to note that they are receiving funding outside of the Office of Behavioral Health.
What are the acronyms under?
That is a great question. These are CDC federal grants, and I don't know what the acronyms stand for. We can figure that out.
I know some of them.
Oh, great.
The SPF is the Strategic Prevention Framework, and so it's specific to prescription drug prevention, and geez, I know what the PDL is too. It's prescription drug.
Preventing
Yeah.
These are state programs or federal programs?
Federal.
Prescriptions
They're federal.
Opioid overdose.
Yeah, so these are federal programs
Okay.
that go through the
This is
state.
federal funding that goes directly to CDC.
I personally, you're the council, but I personally think it would be helpful to have information about, of this, how much money we talking about, like what percentages of that money or each of these line items, personally.
Sure. Yeah, we're happy to follow up with CDC and get that information.
And I don't, I sort of leave it to you whether it's appropriate for you to follow up or whether we should follow up. I mean, I suppose I can work to make that ask, but
It's not a problem for me to follow up with CDC.
Just on that thread, it would also be helpful if we're asking how much money is going to what thing, like under the harm reduction, it says 7 million allocated, but how much does certain service programs and how much does options and how much does the Naloxone get of that 7 million?
Yes, I do have that breakdown, so we are happy to provide that to folks as follow-up.
It's relatively easy when it's coming from the prevention and treatment fund, because it's such a discrete thing in it, and we put that together every year. I mean, we've been doing about $1 million a year. By far the largest amount out of that pool has come to support the syringe exchanges, because there's been no money in the CDC budget allocated for that. So we have stepped up for 3 years in a row, and that's been the largest amount.
It's a great question, Courtney. So for example, within harm reduction, the big three, I guess I would say, would be funding options, our options teams at 1.3 million, the options media campaign, which is about $1 million, and then the Naloxone distribution, which is about 3.3 million.
Okay, and how about certain service programs?
As Gordon noted,
It's
that's
$1 million.
funded through the opioid prevention and treatment fund.
Oh, okay, so like certain service programs got 1 million, options got 3 million, the media campaign got 1 million, and then the Naloxone got 3 million?
Correct.
But that's not from the same funding source.
Okay,
The only piece of that comes from the prevention and treatment fund, I think, is the syringe.
Correct.
Okay, but do you have that for all of the, I wasn't pointing harm reduction out for any reason, I was just open to harm reduction. So do you have that in like a memo that you could send for all of the pillars here?
Yes, we do have the detail. I think it would take us a little bit of time to scrub it to make sure it's understandable, because these are like program categories that get tucked into a financial tracking system. So I would just need some time to make sure if you were reading them, you could understand, what they were referring to.
Okay. I'm not trying to make more work for people, it's just a question.
It'll be interesting if also, if in the new budget, if those are being increased or decreased in the new budget, if that's possible to do that. It'd just be interesting, I mean, again, if this committee's looking at supporting programs and looking at gaps, using some of our money to gaps, if you have a program here that actually is going to decrease in funding or increase in funding in the current, in next year, it'd be interesting to know that.
And some of those are being increased because of funding from the Attorney General's piece of the settlement.
Correct.
From his conversation with that's where the money is coming to double the number of options liaisons. And that's where the money is coming from, some additional naloxone purchasing. Yeah, so it's not part of the general fund. That happens to be out of the 20%.
Directionally, though, perhaps coincidentally, the money that's requested in the 24-25 biennial budget is to maintain services. So we're looking to preserve the increases to programs that have been made over time. Like Sarah mentioned, with some of that being done through one-time federal funding. So we need additional funding from the state to preserve those current levels. So I think largely it's not an increase or a decrease in either direction.
It's important, again, it's sort of like when I asked the question of how much was ARPA funds or how much was funds from the pandemic dollars, so those are important because we know that those go away. And so if we're supporting important programs with that funding, what is the goal sort of continuing those programs, particularly if we found them to be impactful to the community. Thank you.
Okay, so a few follow-ups there, thank you, and we will follow up with CDC to get a bit more breakdown on this slide in particular in terms of totals and the allocations for each of these funding areas, and we'll spell out the acronyms for the funding source. I did want to highlight a couple of new notable opioid response activities. Gordon has alluded to a few of those just to make sure the council is aware. In 2022, we did put out, as I mentioned, a capital and catalyst RFA to expand SUD residential treatment across the state. In total, that was about $4 million for the capital RFA, was about $2 million for the catalyst RFA. We have several providers that have been successful applicants to receive those funds, and we have projections as it relates to increased bed capacity across the state as a result of that. Given the success of that and what we see as continued urgent needs, we are doing a second round of an RFA that's going to combine both aspects of capital and catalyst funds. So an additional $2.5 million will be available, and that RFA should be published within the next month. I also have a more detailed breakdown on SUD residential bed capacity. If the committee is interested in seeing that, I actually brought some copies of that I'm happy to pass around. And it does delineate between SUD residential treatment and medically supervised withdrawal treatment. So I just think it's important that we keep that in mind in terms of capacity and additional opportunity areas. So I'm happy to share that as well. Also, as Gordon noted, the OAG has agreed to provide $3 million of their settlement dollars to support the expansion of our options team statewide. We see this as a tremendous opportunity to go from one individual in the community to more of a team-based approach across the state. And it will allow us to double the number of options liaisons across the state. We're also using some of the opioid prevention and treatment funds to continue to increase our naloxone distribution by 25%. And there were 3 new initiatives through the Office of Child and Family Services I also wanted to highlight. I'm sure this group is aware of the intersection between child welfare involvement and substance use. And so this is an area we have also really wanted to target resources. So as a result of that, there are several funding pieces that are now going to support some of that child welfare work. We're using some of the opioid prevention and treatment funds to embed SUD counselors in 8 child welfare district offices across the state, piloting youth peer recovery coaches and recovery coach support for individuals who are involved with child welfare. So again, another opportunity for us as a state to really be supporting.
For the expansion of your options team, maybe this is directed towards Gordon or you, are all those folks needing to be licensed? Are you expanding CADCs or LADCs or?
Not necessarily. We've had 2 listening sessions, one with the liaisons themselves and one with the employers of the liaisons, which was yesterday. And one of the questions they've been asked to address is, do you think that the existing level of qualifications needs to be retained? And I think it's fair to say we've heard mixed reaction. I mean, some people, and people with the credentials, think it's really important, and other people would rather have a person with lived experience. And it's not necessarily one size fits all. We, through Catherine's efforts, we have waived from time to time that requirement because there was we couldn't hire anybody in some of the locations. So it's a bit unknown, but it's a question very much at the heart of the expansion. Another question being, do you think what you need in your county is an additional person, additional liaison? And certainly 4, 5, 6 counties say, hey, yeah, it's a big county, and we, just for geographical coverage, we need an additional liaison. Others saying, oh, we don't need a liaison. These are the people we have available. Maybe there's other liaisons there and embedded in police and other co-responders. What we really want is a recovery coach that we could refer to. So we're working on it. What's nice is to have the resource, and the different counties will get different resources depending on what they need.
I only asked because I didn't know where you were going to find them.
Right. I agree.
Exactly. It's true. So I need to say that I can't be more, I have no idea how many years I fought for substance use counselors to be within the child welfare districts. But what do you do for districts who don't have an office? And I'm thinking like Piscataquis County, they don't have an office. Do they still have the availability to access an SUD counselor through the child welfare system within, because I think they're there one day a month or something, that they're up there, because they don't have an office in Piscataquis County, and Piscataquis County has a high need for treatment.
That's a great question. I don't want to speak for Dr. Landry from OCFS, but I know they have had some conversations about sharing the resource across different areas. So they're still, I think, ramping up on implementation, but I think the goal is that all offices or areas, regardless of whether we have a full-time office open, have access to this.
It's great to hear about for years.
Yes, it's very, very exciting.
Another question?
Okay, so I wanted to make sure we just highlighted some of the newer initiatives and funding opportunities and how we're leveraging those funds. And then we had done a little bit of thinking about, given the role of the council, the opportunity we have right now to leverage some of this funding to continue to advance our work, some of the areas that we see opportunities to really expand or target resources across the state. So the first category or priority area, I guess I would say, is just really expansion of our activities that have demonstrated impact. And I think we'd all agree that, fundamentally there's, some grounding around activities that we would want to see in terms of being aligned with the governor's opioid strategic plan, that our efforts are complementary and coordinated, and can focus on strengthening some of our existing efforts. And again, we know we can't solve the problem in one part of the system, so really looking at things from a statewide holistic approach. One area that I did want to note for the council for consideration is that we did establish the first crisis receiving center in Cumberland County, which is designed to be kind of a low barrier, same day access, walk-in access to mental health and substance use supports. What's really interesting about the Cumberland County Crisis Receiving Center is that it blends together several evidence-based practices as it relates to kind of a living room model and having access to peer services, or the traditional clinical model by which you might want to meet with a counselor or peer services. And there's a 24/7 component to it. So the implementation of the Crisis Receiving Center in Cumberland County has been quite successful. They've been really ramping up their service delivery, individuals able to access that kind of low barrier walk-in, same-day support. It's designed to divert away from law enforcement, emergency departments, and law enforcement can also do more handoffs and drop-offs at the Crisis Receiving Center as well. So something to consider is, could these funds be leveraged potentially to expand crisis receiving centers in other areas of the state? So something to think about. And I'm happy to provide, we did a post 6-month evaluation pilot of the Crisis Receiving Center. So some of the data that the council might find useful and helpful, we'd be happy to follow up with as well. Of course, there are always opportunities to continue to expand our naloxone distribution statewide. And again, perhaps to look at a little more targeted way, how do we ensure that naloxone is available to individuals given the risk related to the child welfare intersection? Is there an opportunity where we could target access to naloxone to support individuals involved in child welfare to promote safety for children in our state? So again, just something else to think about as it relates to naloxone expansion. Also, we all agree that stigma remains one of the greatest barriers to access and treatment and supports, both here in Maine and nationally. And I know that Gordon has done some work and has been interested in an evidence-based anti-stigma campaign that would be led by Shatterproof. So again, another opportunity area for us to think about. Gordon, I don't know if you want to say more about Shatterproof.
Shatterproof is a well-established non-profit foundation started by a fellow, Gary Mendel, who lost his son to an overdose a few years ago, and he had resources. He was in the hotel business, and it really, he's really worked hard to focus on two things. One is stigma, and the other is the quality of treatment. As he was sending his son to places all over the country, he was very unhappy with the information that he could get in terms of the quality of those organizations. He's done a wonderful job. And they did an anti-stigma campaign in Pennsylvania that's now spread to 4 or 5 other states. We talked to him 2 years ago, but we didn't have any money. And now we have some resources, and so we met with them. I included, Pat was part of that conversation. I think Madison was as well. And it's only of interest to us because it's evidence-based. It was evaluated by the University of Pennsylvania, frankly. And what they do is they do surveys ahead of time to see, for instance, would you, they ask the general public, would you, how would you feel about a person with substance use disorder living next door to you or marrying your child? And then they do education, and then they ask the questions again. And they've been able to show a mathematically valid change in people's attitudes. So it's pretty interesting, and again, it gets good reviews from the states that have done it. So that's really what that's all about.
Thank you, Gordon. One of the other areas, and I just had the overview list passed around, which is our current SUD residential treatment bed capacity across the state. This has been a real focus of Governor Gordon's work in terms of expanding access to treatment and for supervised withdrawal. one of our recommendations is that as we get the second tranche of the RFA out, that we really step back and evaluate the impact of that RFA and identify regions where there still are substantial barriers, particularly to accessing medically supervised withdrawal, particularly in residential settings. There is a big difference between access in an inpatient setting for medically supervised withdrawal and a residential setting. And you'll notice as you look at what was passed around in terms of projected new beds under the SUD capital RFA, a good amount of them are residential medically supervised withdrawal, but not as many as we would like to see. So again, I think there is an opportunity for us to consider where are the regional gaps? Could we target more resources to ensure that for that individual that is ready on that day, that they are able to access that medically supervised withdrawal treatment as soon as possible. I think right now in some areas of the state that's very difficult. The next one I wanted to highlight, and something we've been thinking about and are quite excited about potentially, is implementing mobile MOUD units across the state, including methadone. Other states have had success in implementing mobile units. We've had some conversations with providers as it relates to their willingness and feeling like they have the capacity to do this. So something for us in Maine to consider, which would certainly expand access. Could also support some of the conversation that we were having about accessing MOUD in jails, which would break down some of those barriers, particularly as it relates to transportation for methadone treatment.
When you say mobile units, what exactly do you mean? Like units, like a bus, a van going to people's homes, or going to, let's say, the local Irving and setting up shop where people show up there?
That's exactly right. So both mobile unit, I don't know about going to individual homes, but I'm assuming maybe Catherine could speak to some of the models.
It wouldn't be necessarily going to the homes, it would be setting up in an agreed upon place. In other states, it's like in a pharmacy parking lot, and then it's closer to some of the more rural areas.
And that would probably save us some money with motive care for those kind of services that we're spending.
Exactly.
Ridiculous. I don't think it's ridiculous, it's needed, but we just have that unit right there. Got it.
And some states have also utilized those mobile units specifically for jails as well. Again, I know that one of the barriers that we were just talking about today is transportation as well, particularly as it relates to methadone treatment. So again, something to consider that could be a real opportunity for our state. And
Yes, Liz has a question. I'm wondering if you have the number of beds that accept Maine Care in terms of this. I'm sorry, I'm going back to this residential treatment bed overview, and the ones that accept Maine Care, how many beds they have that are for Maine Care.
that is a great question, and we can follow up on
I think that the only one, because if they take our new money down here, the new stuff,
that.
they have to get Maine Care. The existing, I think the only one we've made real headway with Pine Tree. I think the only one that really is not welcoming yet, and we are working on it, is Liberty Bay. But Liberty Bay has started participating in the OHH, I think. So there's certain elements of Medicaid that they are participating in. So we're really working with them and their medical people. They're owned now by BMR. Huge behavioral health organization across this country. So that's the only one that I know of that's not participating in.
And so you're saying that all of the beds that are numbered here would be available for Maine Care, or do they have certain, I mean, I know it used to be a certain number of beds.
So I think I can clarify some of that. So when you call a treatment center, for instance, for years I worked for Wellspring, so we'd say to people, we would set aside so many beds for non-Medicare people and so many beds for Maine Care. And that had to do with our funding sources. So all of the beds within, for instance, Wellspring, all of them could receive Maine Care. We were licensed to bill 15. We would set aside, because of grant dollars, we'd say 3 of those beds are gonna go to people who are uninsured.
Mhm.
The other were main care beds, but within the facility, all of the beds, we could have billed, just taken Medicare patients, main care patients only. But most places, what they do is they supplement with scholarship, what they call, Crossroads calls them scholarship dollars. That's grant dollars that are received by the state, and they supplement them.
But I guess I was under the understanding that there are some that will only set aside some for main care because they want insurance payments for the other ones
Or they
at a
could-
higher rate. And so I guess I'm curious, like how many, if we called, name one of these, and said, I have main care, and they say, well, our main care beds are taken, there are these other beds. I guess that's what I'm wondering,
Yeah,
because
and
I keep hearing that there is this
And that's,
problem with folks who call and they have main care, but they still can't get access to their
That-
residential
and I
treatment.
think that's the financial thing within the agency. Like, when I worked for Wellspring, I would know I had to have a certain percentage of main care clients.
But I guess I'm asking the question because of the fact that because if we still have such a lack of beds for folks with main care, I guess I want to get deeper to the question of why aren't they willing to take more main care beds? Is it still, I know you've done a great job of increasing the reimbursements rates, but I guess my question is it enough? And are they willing to take the rates? So I guess I'm trying to get at why are there still not enough beds? You know, I guess
We're waiting for these beds, it takes a long time to get them
Yeah,
online,
yeah.
but we're waiting for the beds down below.
Okay.
And then we've got the new group coming into Brunswick with 40 beds, and they will take main care. There's only one outfit here that I know well, and I worked with them so that they would take some main care, and that's
Mhm.
Bella's House. So Bella's House is filled, it's way up in Springfield, Maine, outside of Lincoln. It's filled most of the time now, men and women, but they are participating in main care, and so they will, if they have a bad day, they will take some. That's the only one that's limited. I did misspeak, however, because I didn't realize that McLean Board and Cottage, owned by Mass General, trust me, they don't participate. I think in any insurances, it is a very high-end cash deal. A handful of beds available at the old Charlie Colley's old residence. He was the president of the big company.
Yeah, great. Well, and I'm sorry, one other question is just around, in terms of related to residential opportunities for young people. And I think I'm interested in what is available, because I, again, keep hearing a lot about young people who are having behavioral health crises and, mental health crises or suicide attempts and have nowhere to go and are ending up in ERs for very long periods of time. And so I'm wondering if there's a way to get some sort of breakdown on what's available currently for young people, and this might be totally unrealistic, but I feel like we're missing this tiered system of support for young people. It's not like when we get outside of school or outpatient, like minimal outpatient, like intensive outpatient and residential seems to be very limited.
Yeah, you have a list that you can send us, because I don't think any of these beds are for adolescents, these are adults.
I don't know why day one isn't.
That's what
on
I
there,
just looked for,
because
day
we-
one isn't listed.
Day one should be listed on there. They are renovating a building they own to reopen their adolescent women's facility. There's only 6 beds, the 6 beds we don't have now. Their previous women's facility was given over to young men because there was more demand for that. So that, but there are other youth beds up in different parts of the state. There's some in Calais, for instance. So, but there's also, we would get that information honestly from OCFS.
Okay.
Because they have a substantial program going to enhance adolescent treatment. They've done a series of echo sessions to recruit They did quite a training session. The goal being to have pediatricians and family physicians be more comfortable in treating adolescent substance use disorder. And those were quite successful. So to the extent that some of those people might end up in a hospital, and so it's not where we need to be.
Yeah.
But it is not being ignored. There's a lot of interest. We all get those calls. And we're growing that number of both outpatient providers and beds.
And mine isn't a criticism, it's a can we know, so that when we're thinking about where we want to spend money and time and energy, it's a like, you're sharing where we're at, and I'm getting at a where are we at with young people too.
Yeah, I'll follow up with OCFS. I'm also not clear as to why day one isn't listed on here, so we'll follow up with that information.
Courtney, any other questions?
I just have a statement. I thank you for this list. I am gonna send around a map that was created by advocates and organizers on the front line, and there are currently 26 Maine care beds for medically managed withdrawal that are operating in the state of Maine right now that accept Maine care. Those are New Horizons, 10 beds in Bangor, 16 beds in Portland with Milestone. This tells us that there's currently 20 beds coming online, which we're going to be at Milestones and at the Wabanaki Public Health, and that a private provider is going to be bringing on 20 more beds in Cumberland County. So there's 26 beds that are currently online right now, 20 beds coming online from the RFAs and RFPs, and then 40 private beds coming online for medically managed withdrawal that accept Maine care. And I'll send them out.
Can I just ask the question, how, and maybe it's just relevant for these new beds, how is this management different for these beds, I got the existing beds, how is it different than the PNMI gatekeeping process? So your department manages those beds well. How does that look different with these beds? Will there be a prior auth process? Will your department have a voice? Like right now, the PNMI beds are determined through gatekeeping. So is that in the cards potentially?
No, how we manage our mental health residential beds is very different than the substance use residential beds. So you're correct, our team manages access to the PNMIE beds, our residential beds across the state. We have priorities as it relates to the consent decree. So that is kind of the backdrop for that. So it's a very different in terms of we're providing funding to get more capacity up and running. We don't have the same level of gatekeeping oversight as it relates to the SUD residential beds.
It's a good point, I forgot. How could I forget the consent decree?
I don't forget about the consent decree.
I'm gonna I'm looking at people are looking like they need a break. Would you like to wrap up?
Sure,
And then we
me too.
can take a short break and then we'll bring on the national, or do you want to keep going?
A break is on
A break would be
Yeah.
good after she's all set.
Okay.
Miles?
Just very quickly.
Yes, of course.
Is there any way we can get a list of Maine Care reimbursement, how much Maine Care reimburses for each of these residential services?
I would think Maine Care could give us that then.
Yes.
Well, you can, you can tell by what they're licensed for, and then the rates are listed in
Right
the
in there.
main care sections.
We're happy to pull that information and provide it.
Because you don't really tell what type, you do say sort of, you don't say here what type they are, and that would depend on the reimbursement.
Just real quick,
Yes, of course.
this slide here, priority area 1 and 2, are these things listed should the council understand these to be listed in priority order?
I would not say that, no.
So it's just like,
Just the
whatever's up here is great.
Yes. We did not go through a prioritization process of 1 through 6. Again, I mean, we have to strengthen the continuum, so we see them all as being urgent and important to continue to advance the work. The one I haven't gotten to yet is, I think, germane to the conversation we were having earlier about expanding access to MOUD for incarcerated individuals. We really see an opportunity with the settlement funding to expand resources to support our county jails, which we talked about earlier. As Gordon mentioned, we're looking forward to meeting with our county jails and other providers on Tuesday. But this is an area that I think has demonstrated unmet need across the state. And priority area 2 is really, I think, to all of Liz's good points, how do we continue to keep our eye on prevention activities? There's some great work that's happening in collaboration with the Children's Cabinet, because prevention is beyond just the Department of Health and Human Services, it's the Department of Education, so community members. There's a lot of great, at the ground level, community level building that's happening around prevention. But again, I think the Children's Cabinet is doing some very targeted work to identify some priority areas. So I think it behooves the council to invite members of the Children's Cabinet, Hannah Hicks, who really leads that work, perhaps have a conversation about some of the opportunities as it relates to prevention.
And I just want to flag for the council, just real quick, that you can find support for, I'm not suggesting the council ought to focus on these things. I'm just saying that anytime somebody comes to you with a list of priorities, it's a good idea to look at the approved uses that the council can spend money on within the MOU, which are exhibits 1 and 2. Just pick one or the other, 1 or 2, because they're the same. But I just kind of went through these and found support for all of these in the core strategies, which are Schedule A of the approved uses. You may recall that Schedule A is sort of the highest priority. These are, if all you did was this, probably make a big difference in your community. Schedule B is a broader menu that takes you down lots of other roads. But I was able to identify, all of these priorities in Schedule A, at least I think.
Just wondering, how much coordination, if any, is being thought about with this, particularly 1 through 6, with the expansion of CCBHCs? And if you folks are working together with, obviously the Maine Care being involved in OPH, is this something that, because I could see maybe 3 or 4 of these categories that might fit in with some of the goals of CCBHCs, maybe streamline some of the payments from Maine Care. Is that been talked about?
Yeah, it's a great point. I was going to bring up CCBHCs earlier when we were talking about prevention, but didn't want to take us too far down another road.
Sorry.
No, I'm delighted. CCBHCs, I think, are potentially a transformational opportunity here in Maine, establishing certified community health clinics across the state that can create an integrated hub for mental health and substance use services, and perhaps more of a regionalized system of mental health and substance use care here in Maine, which would just be tremendous. So I fully agree. There are huge opportunities to leverage CCBHCs over the next few years to support some of this work. It doesn't mean we can't start now to make sure that we get the ball rolling and think about the CCBHC system as potentially an option for us to embed some of these services over the longer term, because we're still we're laying the groundwork and creating conditions right now for the implementation of CCBHCs, the infrastructure to support them, the payment model. So we're about a year out from having that work done, but I fully agree with you.
You've got an amazing team. There's an amazing team of folks working on that. And I, it's just making a comment, it would be so neat to have that mobile unit be anchored to CCBHC. And I'm sure it's much better ideas, but it's a great thing.
I agree. And the more that we can have regionalized models achieve that scale, I think it's a good approach. So the last slide is actually Gordon's. So Gordon will have the final word.
Well, I want to, I assume Madison had a chance to introduce herself before I came in. I mean, she really put this together for me, and then I want to mention a couple things that we haven't gotten to yet. So these are sources of funding that do not come through the Maine Department of Human Services or OPH. So SAMHSA, HRSA, the federal CDC, they all on occasion have direct grants into organizations in Maine that we might never know. Now, it's a small state, so normally we figure it out eventually, but it's really important for us to know you know, this group to know, and, you know, Western Maine Addiction Recovery Initiative has a $1 million PERSA grant, which allowed them to open up that Hills Recovery Center the day before yesterday that the governor and I were at. And so we're trying to get better at being able to track what we have. And so these are federal sources that don't come through the state. They come directly into Maine. The congressionally directed spending, we used to call them earmarks. They eliminated them at one time. Now they're back. I was really skeptical until people started getting checks for $1 million. And then I said, well, I guess we better get going. I know that Senator King's office got 360 requests this year for the next spending. I'm sure Senator Collins, they've been more generous on the Senate side. The House has cut back a little bit. So, but it's really important for us to know these things. And honestly, we've got most of this stuff off their website, or personal knowledge. I know that Milestone got a $1 million earmark a year ago. Up in Millinocket, our recovery center up there got like $400,000 so they could move to buy a new location and move to there. So I think these are all things that you need to know because they are sources, funding coming into the state. What we've not picked up is the other department spending. So obviously we've talked today a little bit about Department of Labor, Department of Education, Department of Corrections. If I ask Commissioner Liberty, how much money in your annual budget is being spent on substance use disorder treatment or other initiatives in the Department of Corrections, it'd be millions of dollars. We can get you that information, but I don't have it ready today. I almost think that almost every department of state government has a little or a lot that they would attribute to opioid, substance use disorder, what have you. And then there's private philanthropy, and I don't have that piece either. It's more difficult to track, but I do have a funders group of private philanthropists that I meet with every quarter, courtesy of the Maine Community Foundation, as well as the Maine Health Access Foundation. And there are a lot of philanthropists in Maine and nonprofit philanthropies that are interested in helping Maine with this issue. So for instance, up in Betsy and Chassidy's area, the Maine Community Foundation is funding a pilot for us run by the Community Caring Collaborative on recovery-friendly work sites. I think we have a listening session Monday morning. So it's not huge money. That whole thing is less than $50,000, but there's a lot of those little things that private philanthropy has stepped in and helped us with. So I wanted you to be aware of that. Is there anything I missed, Madison?
This isn't really a question for you, but you probably know as well as anybody else in the room, I'm guessing. The other piece of funding information that I think the council doesn't have at this time, and so I'm asking, is there a source for it, of spending on this kind of work at the county or the city or the town level?
I don't. I think we have to give thought to, now that they have, the key to that is the fact that they now have some settlement.
Not just the settlement funds, I mean,
but
there
other,
could be anything, like from any, like, to some degree it'll overlap with what's been presented here.
Sure, but like
You know,
like
some are
York
spending
County,
their own money.
York County is spending $33 million of its ARPA funds to build its own treatment facility and staff it. So, yeah, I've not tried to capture that, and we'd have to think about how we could. I think
if the council's gonna organize its thinking about how to spend money, and it wants to get a picture of what money is being spent on the opioid crisis by anybody, anywhere, that's a piece of it.
yes, yeah, I appreciate it. It's a piece I hadn't thought about.
So I'll take one question and then we'll go for break.
A quick comment. I do think there are ways to not slow us down, to say like, what is everybody getting money for, and build it into our the way we ask people for you know, saying like, okay, you want this money, please also share with us what is the other money that you're receiving, or that the other resources that are happening in the area that you are working in. How are you gonna coordinate with the other folks who are doing this work, so that we get that as they apply for funding and we piece it together, instead of like waiting to find out what everybody's doing, because it will take forever to collect that. But I do think it's also a way that we can support collaboration, is to say, you know, we want to see collaborative projects are gonna have a higher weight than something that's, you know, I don't know, just throwing that part out there.
It's a question, I know that I review United Way grants, and it's a question we ask people. They submit a budget, we have to know where your other funding comes from your program, so we know whether it's federal grants. But United Way also puts in there that we can't be more than a third of your budget. So we know that. So thank you for that. Thank you very much for coming
Absolutely,
here
my pleasure. This has been
and
wonderful.
listening to all our questions, and we certainly have given you some
A little bit
work
of
to
homework,
do.
yeah, thank you.
I will say personally, Catherine, it was great to see you again. Catherine and I worked together years ago. It was nice to see you. But thank you very much. We have a person coming in to speak on the national perspective. So if we could take like a 5 or 10 minute break and try to start like at 3 o'clock.
Don't go by that clock.
Oh, God, what time?
Oh, that house is true. I don't think so. I'd like to start again, get that rolling by, at least by 3, but thank you.
And, you know, please take some of the food, so I don't have
I'm
to
gonna
take
get
it.
my thing.
Yeah, we don't want to even.
All right.
It's so nice to meet you. I've never heard so much about you from other folks. You're Lisa, actually, with her, she was like, yeah, come on, go to one meeting and then we'll work on it.
No, we're on a break.
It's great to be here.
Just to bring it.
Yeah.
All right.
Well, I was wondering. No, but there was no way to. I like that. Yes, and I was thinking about you because when you were saying that, I'm like, okay, the initiative, yeah, of course, in this big. Try to do it from little places. Very hard. Yes, but they are welcome.
Yeah, I mean, yeah, that's what it costs to pull it off and sand it down, paint it, that's the cost. Yeah, well, my concern was just the turn, so I want to make sure. But back end. I think it's keep that under our hat.
Here's the oars, here's the discrete stuff, here's why you can do it again. We fund, like, not,
Yeah.
I used to, I
Nick
wrote
has
those
switched off
ones
the
for
swap.
our and I connected them, and so I worked with them for a while and had management. And then they just came to another one and loved it.
Thanks.
So I guess I'm thinking.
Yeah, I know.
The bigger funding than the city.
I've never
They
met
did, and then I don't.
I've only seen you on screen,
Yeah.
great to meet you in person.
So, Wynn and I met with, when I was working for them, we met with a whole ton of.
I did, Brad, you're right.
Yeah, I heard, like, that.
Oh, it was, oh,
Larger.
Yeah, I know, yeah.
They're really interested, so I'm saying, because I know the people who are. Yeah, with Sheila, right.
we're doing right
So
now.
I told her that, but I'm just. Like it's one thing when I'm excited, but I feel like she can know.
It was just a call on Friday.
Amazing. So anyway,
Have fun with
and I
it.
love it. They just came and we had dinner together and it was
Maybe
really
needed
nice.
help just got.
Oh, so nice to meet you. Thank you so much.
Of course, my
All that you
pleasure.
provided, I really appreciate all your.
How are you? Conversation outside.
Funding amounts, it like
Yeah.
feels great to see it.
Exactly, yes, yes. Still have a lot to do, that's for sure.
Yeah.
Oh, okay, nice. How about you call class?
So glad to hear that. This is awesome.
3 days a week, so that's 3 days a week. Yeah, coming here from Vermont, I was like,
Yeah.
you know, good jobs and. Yeah, great.
Anyway, so it's great to have you.
Take care. Thank you.
Very nice to meet you.
Yeah, likewise, and we'll follow up on all the follow-ups.
Yes, yeah, I know we sort of, I'm sorry.
Now that's the nature of it, and we have a little
I think it would be great to, you know, also to like that back, because I feel like there's a lot of detail that.
Oh, yeah. Good each other, then well. Yeah, I'm happy to come in. Oh, perfect. I sure do, that is. A lot of good things. Exactly. Exactly.
Oh, that's good.
And that's why I'm.
Giving me chills.
I know. Yeah, he did. And he does great work. Yeah, oh, yeah, thank you.
Because I realized.
Sometimes it's a learning curve.
As
Yeah,
I
this is
said earlier, this is the.
I'm sure Mike's helping me with that too.
But I had some application on this one, you had, and I'm like, you know, once, you know, Sarah Squirrel come to present. Just one presentation here.
Done now. But yeah, I'm happy to come back.
$20-something million.
We may not be able to provide some of this stuff we should talk about, but maybe, yeah, and you should know also that, I appreciated your slides were excellent, but to the extent they were organized around questions. Those are my things. I didn't exactly.
Old men too.
Exactly. And I spent, I got kicked home, it's a great framework, and it worked, I think it led to a lot of great discussion, and they.
But it also raises the data, you may understand.
That time I was still very much.
That's the good part of it.
Yes, it was.
Yeah, you too. I think it's so funny just to like every person that you like always go with.
And I gotta tell you, that kind of interfered with me for a little while. Because when she first started talking, I literally came out of my chair. Because I thought I was okay.
Yeah, worked a lot with TJ. And his team, and then whoever the second commander was.
What is it?
Yes, yeah.
I found her.
So, talk about like YouTube and all of that. We have more than two this point. So the reason I have to get together is now it's like things like training. But we're all very happy. We need to get together just to like catch up.
Come on now.
Yeah.
Residents.
All right, so, this morning we got earlier today, we got a presentation on where we are as a state. So I thought it'd be interesting, and, I've actually got to sit on some phone calls on the national perspective from the National Academy for State Health Policy, and what other states are doing with their settlement dollars and how they're spending it. And had a brief conversation with Katie, in regards to that, so I thought I'd bring that to you today, so you can get it. You have her PowerPoint, this is her PowerPoint, it's printed out over there. And so at this point, I am gonna turn it over to you. Thank you for joining us. Hey.
Great, thanks so much. Can everybody hear me?
No.
Okay, good. Okay, well, thank you so much for inviting me here today. My name is Katie Green. I'm the Director of Public Health for the National Academy for State Health Policy. For those of you that might not be aware, NASHB was proudly founded in Maine, so excited to talk to you all today. I'm going to try to go through kind of the landscape of national settlements across states, kind of where they are in the spending process and some of the key things that they're thinking about, and I'll try to get through that in enough time to answer some questions. So I think I was going to share my screen here.
I can do that for you if you want to leave yourself visible in the corner. And
okay.
Oh wait, if you want to do it actually, then you'll have control of the slides.
Okay, here we go. Okay, can you see those?
Yeah, and I'm going to go ahead and mute us so that we don't pick you up through our speaker in the room, and we'll save questions for the end.
All right, sounds great. Okay. And there we go. Okay, so for those of you that might not be aware, NASHB is a nonprofit, nonpartisan organization committed to developing and advancing state health policy solutions. We like to say we're of, by, and for the states, and we have an actual committee that guides and provides feedback on our work. We are not a membership organization. We work with the full spectrum of folks working on health policy across the executive and legislative branches. We have the goal of improving the health and well-being of people across every state. And to do so, we conduct a couple activities. We do tracking and resources. We're really a convener where states can get together and share resources and ideas. And we also do technical assistance. So working on a lot of different issues, of course, across the healthcare spectrum, but a real focus of the organization has been on improving access to opioid use disorder, substance use disorder, and really expanding access. And this work has been in collaboration, partnership with the Foundation for Opioid Response Efforts. And over the last year, we've really focused on supporting state leaders with administrative planning for state opioid settlements and really thinking about how to maximize the impact of that funding. So our Opioid Resource Center has a couple of really great resources I'd urge everybody to check out. We've got a tracker where we do kind of apples to apples, looking at state administrative structures, how different states are set up. It's a good way to check out if you want to know what other states are doing. We do blogs on emerging issues that we're hearing a lot about. And we also have a series of webinars, including one that I know Gordon spoke on early on. And then one of my favorite parts of my job is our state opioid settlement learning network, which I think Pat mentioned. And it's a monthly meeting of folks that have decision-making authority for state opioid settlements. And really just a forum for state-to-state learning and discussion, for raising challenges and questions and seeing how other people are approaching challenges, like how to collaborate with partners, how do you think about reporting and transparency, how do you think about alignment of different opioid funding streams. So a lot of really rich conversation, and we've been happy to have Maine participating in those. So this slide, I apologize for the wall of text, but Pat had indicated that y'all might be interested in knowing kind of where Maine sits within the region, how it compares to other states. This is just an overview of the different New England states and how their administrative structures are set up. And there's a lot of commonalities here, honestly. There are nationally, there are legal frameworks and MOAs or MOUs that really sort of outline roles, relationships between settlement participants and how funds are divided between state, local, and other entities. All New England states have legislation, MOAs, or both. And they also tend to be pretty heavily centralized. So a big chunk of the state funding flowing from state or statewide abatement funds rather than going to the locals. There are some instances, I think North Carolina and a handful of other states where the vast amount of funding is going through the locals. So a lot of sort of among smaller states, it's not uncommon to see a sort of centralized role here. And then, the actual disbursement looks different. Sometimes it's the advisory council that's tasked with doing the disbursement. Sometimes it's a state agency, but all New England states have some form of advisory council that provides input, recommendations, and over settlement spending. Just in terms of how Maine compares to some other states, Pat shared some of the characteristics of Maine. I don't need to go over them with you, but we did identify a handful of states that share some commonalities in terms of having a significant rural population with some population centers, being relatively small and having similar abatement setups in terms of having an advisory group, having a state local split that looks somewhat like the default allocation within the national settlement, and then an abatement fund. So really what everybody wants to know when they talk to me is where are different states in this process? And the answer is really there's incredible variation across states. On one hand, you've got a handful of states getting money out the door already. And then we talk to a lot of states every day that are still setting up those administrative structures, still thinking about their grant processes, still thinking about who's on the committee. And that's particularly true of states that have had some recent turnover at the state level. But we have identified 17 states that have announced uses for an initial portion of settlement funding. And when I say that, a caveat that this is changing all the time, that this is based on what we are able to find publicly, but and it does run the gamut from sort of putting out high level recommendations to actually line item budgets about where the funding is going and to who. Again, on a national scale, 13 states have either published annual reports. These are often required by law or within the MOA, and can just tell you where they are in the process, spending recommendations, or both as part of that report process. Again, we are not seeing a lot of states that are actually starting putting out money, but we are starting to see some examples. Some that I can point to are Massachusetts, Wisconsin, and Rhode Island have gotten some funding out the door. We've also seen, as described in the last slide, some states that have at least at a high level talked about some of what their funding priorities are. Just my own personal observation, it does seem to be spread fairly evenly among prevention, treatment, recovery, harm reduction. People are thinking pretty broadly, but in terms of the money that has gone out in the more immediate term, Wisconsin is a little bit interesting in that they gave a significant chunk to some of their tribal nations without a lot of stipulations about how that would be funding, how that would be spent, given that they would be in the best place to make those determinations. But otherwise, we're starting to see funding for a lot of harm reduction, fentanyl test strips, Narcan, harm reduction generally, community-based outreach, and a lot of housing supports, which is consistent with what we've heard from states in terms of their priorities. One of the other things that we spend a lot of time talking about, and we have a blog or issue brief on our site that sort of outlines some of these, is just what are the core components of state responsibilities when it comes to opioid settlement funding, and what are some of the things that states are thinking about in this process. And one is of course implementing decision-making processes and structures. Just in some cases, states are really starting from scratch in pulling these entities together, and knowing that there is a lot of pressure to get money out the door. A lot of questions about how their states are approaching that. Some of the other things that states are thinking about are how to ensure that the money goes toward evidence-based practices. How are you thinking about aligning that funding with the other opioid streams that are flowing, especially when there might be limited visibility into county spending? And I know I heard earlier in the meeting that this is, of course, something you all are thinking about. Creation of advisory committees, and in particular, how do you really engage people with lived experience? That's actually the topic of our next SOS network call. So looking forward to hearing more about that. Disbursement of state share funding. This looks a little bit different in every state, depending on how the legislation and MOA shook out. But in some instances, it's delivered through agency. And other times it's really the abatement council itself that's doing the bulk of the work. No matter who is doing where the spending is, though, really coordination is so important. Not only the intragovernmental collaboration and knowing where those gaps are, where the funding is going, but also working with counties who are in most cases distributing a fairly significant share. Promoting public input and transparency, also something that we think a lot about, and can be at tension with some of the pressure that states are feeling to spend the money. Are you engaging the right folks? What sort of processes are you setting up? How do you really do that meaningfully and get the input that you need? And then finally, reporting and accountability. And this, of course, looks very different across different states. But we'll be able to point to some good examples and best practices that we've seen across different states. So just a few issues that Pat indicated we might want to zoom in on, that different states are thinking about. I actually had a conversation with another state today about their RFP process. A lot of states, some states are distributing through grant processes or a combination of grants plus an RFP process, open to state and local agencies, treatment centers, recovery, harm reduction, prevention programs, differing levels of criteria or specification for, how priorities and awards being made on a yearly or rolling basis. Approaches really vary, but we have identified, a handful of states that are actively in that process right now. One that we've spoken to relatively recently is Kentucky. They have a lot of information on their website. They do rolling applications. Any governmental agency or non-governmental entity can apply, and they do have a pretty good FAQ to help people understand the process and a little bit better and answer any questions. As another thing I mentioned previously, really key challenge that I'm not sure anybody has really cracked, but we've heard some thoughtful approaches. If you want to maximize the impact of the settlement dollars, how do you think comprehensively about the totality of opioid funding that's coming into the state? Whether that's federal funding or other initiatives that are happening at the state level. Rhode Island, we actually had a conversation on this topic too, and Rhode Island outlined some of their approaches. They have a process that includes developing feedback and recommendations from a governor's task force. Those recommendations then undergo a thorough review. And then they take a look at those recommendations in light of the other funding that is flowing into the state, and also thinking about things like sustainability and having a plan for being able to fill in potential future gaps if funding is to recede. So this is their recommendation table, just as an example that not only outlines some of the priorities that they're going for and programs that they want to see to meet that need, but also the different federal funds that are filling those needs and where there might be more needed. Last issue is just reporting and sort of more generally the topic of how are you telling the story about where these opioid funds are going? There's a lot of interest. There is people are watching this closely and wanting to avoid some of the pitfalls of the tobacco settlement, for instance, in terms of making sure that this money is really going towards addressing the opioid crisis and having some accountability and transparency for where that's going. So we've heard really a number of strategies, open meetings, public facing websites, annual reports, key performance indicators. Tracking the impact of these funds, beyond expenditures is also something states are thinking about. But it's tough. I will be very honest, as anybody that's worked in this space knows, especially with all the other funding and efforts, tracking the impact of prevention is always very difficult. And expected to be so. Although North Carolina in particular has been thoughtful about how to track the impact on that. Identified again a couple of great examples. North Carolina and Colorado tend to be the best practices that are often cited in terms of transparency. I know North Carolina has the benefit of within their MOA, even though the bulk of the funding is distributed at the local level, some really strong guardrails and reporting requirements about where that funding is going. And they've had a lot of collaboration between the state and the counties to be able to facilitate that dashboard that's going to show not only where the settlement funds are going, but also doing their best to track the impact. Colorado also has a great dashboard, and Massachusetts, a state that shares a lot of commonalities with Maine in terms of their settlement approach, also publishes expenditures in their annual report. So, and this is just a picture of the Colorado opioid settlement dashboard and some of the issues that they're tracking on their website. So that is it. There is obviously a lot more we could have covered, and I know I sort of breezed through it, but please do feel free to reach out to me if I can answer any specific questions. And I'm happy to do my best to answer any questions.
So we can ask questions. All I ask is that you say who you are, and maybe in your focus, I guess, say who you are. I don't know if I'm that wrong. Anyway, say who you are when you ask your question, so she knows who she's talking to, after he's talking to. So, questions on the national perspective and what she has presented us.
This is Paul Winsel. You talked early on about some of the meetings you've been having, some of the webinars, the blogs. Do you have any scheduled meetings that people can join into that would include people on a similar agency through other states to compare notes directly?
Yeah, absolutely. So we have our state opioid settlement network, which is open to state officials and others that have a role in decision making within the opioid settlements. So, certainly we've had plenty of folks from abatement councils join. So yes, we do have a monthly meeting. Our next meeting is Friday, and I'm happy to send you that info.
Yes, that would be great, thank you.
I've actually sat in on, I think, 2, maybe 3, and found them to be very interesting. Gordon asked if I'd sit on them, and again, last time, I think, someone from one of the Dakotas, I think, was there, and someone from Rhode Island, and sharing what they have done. And, I found it interesting, somebody had a question, and I think that's the focus of the next meeting, is how to involve people with lived experience. Which I don't think is I don't think that's the problem we have here. I mean, I think that we're pretty open to that, but I think that's the focus of the next call. Am I right, Katie?
Yeah, that's correct. The anytime you're dealing with 50 states, you're going to have states in very different places. So the states that we're featuring on that one are Washington, as well as Tennessee. So you're going to see sort of a wide variety of approaches and hopefully something a little bit of something for everybody. But we are always listening in terms of what people want to hear about, what they want to talk about. It's also an open forum to ask questions too. So let us know, and we're happy to tee up some conversations or folks in future calls. Yeah.
And if I'm not mistaken, isn't there a one day where you're trying, I think it's in August, that backs off a week, a workshop or something where you're trying to get the states together to have a conversation in Boston? Am I not mistaken?
Yeah, that's correct. And we're planning on sharing a little bit more information about that tomorrow. But we have, of course, our annual conference, the NASHB's national annual conference. It's August 14th through 16th. As a part of that conference, we are going to be having some pre-conference activities, including an in-person meeting of the SOS. Which we're excited about. So we are going to be able to sponsor one person from every state. Would have loved to done more, but that's what was possible within our grant funding structure. So we will be holding that meeting.
And it's in Boston.
You're right, I'd love to go to Boston, Laurie, no problem. You have a grant to fund one person from each state. Can other people go and pay their own way, or does the grant mean that only one person from each state could go?
So we are able to pay for one person, travel, hotel to participate. We will have, I think, limited seating for states to send additional people. If they want to stay beyond that ancillary meeting, we do have sort of our standard state official conference rates, but we will have limited availability for states to send more than one person.
Okay, great, thank you.
Thank you.
This is Kina Thakrar. I'm an IT and addiction doc. I just wanted to thank you for this presentation, and also I was curious for this conference. I would love to see something on equity and like how states are thinking about distributing the funds in an equitable way. For example, I was just really interested in Wisconsin, for example, earmarking the $6 million for tribal communities, and I'd love to just hear more about that and how all of us as states, I realize people are gonna have different opinions, but how people are approaching that, I think would be great for a conference or an economic.
Yeah, absolutely. And you read my mind, actually, and we are planning on teeing up a conversation about that. I think we've gotten kind of little tidbits here and there, and Rhode Island is another state that has thought about this really deeply. And embedded it into their grant processes and how they do meetings. And I think they're a great example, but it's something that we've heard a lot from other states. And I would love to have sort of a focused conversation on it particularly given the, disparities that we continue to see in overdose rates and rising rates of overdose among Black Americans and American Indians in particular. So it's a great idea. And one other thing I'll flag is that, Gordon and Pat know they have an open line to me, but, if we can ever be helpful in linking you with states, if you ever want to know more about a particular state, we are happy to make those connections or share what knowledge we know. So please do think of us as a resource.
More questions?
Is this costing us anything? Like to partner, or I'm just curious. No, thanks.
No.
I know, sorry.
It's a legitimate
I
question
just
to
wasn't
ask.
sure.
Because we have, again, remember we can spend some funds on administrative costs, but that isn't costing us anything. And the conference, that's what we talked about, if we could have more than one person, they're gonna scholarship or, grant one person, but we may wanna send more, we can use our administrative costs to do that. And again, I'm really thrilled because it's in Boston, which means we don't have a plane to take, maybe a bus or a train, but or a car, but we don't have to worry about airfare and paying the cost of that for somebody to go down and participate in it. So we will talk, as we have more detail, we can talk about how much the committee wants to allocate for funding. No. And we can get the information from the other states, I'm assuming, free of charge, if we want to ask information about Wisconsin and how they determined the money that would go to the tribes and Native Americans. We can do that free of charge, I'm assuming.
Yeah, we are separately grant funded. We are here to be a resource to states, so please use us as such. I am not getting paid by you all, to my knowledge. If I am, let me know. But yes, no, we are here to be a resource.
Thank you, Katie. I'm Miles Willett, by the way. Thank you. Sorry. I forgot that piece.
Katie, it's Brendan O'Neill from the AG's office. Just one question. Will or does NASHB already have on its website, sort of a clearinghouse of like sample forms from the other states? For example, like if they, examples of RFPs from other states, or examples of, data collection that different states are going to require. What are the, what information are other states collecting from their grant recipients? Things like that. And separately, I think you talked about this a little bit, but is there a sort of a centralized place where people can identify the priorities that different state sort of councils have decided to focus on? So two separate questions, but sort of looking for a centralized repository of documents and sample documents and information.
Yeah, it's a great question. And of the topics that you mentioned, we did a TA request for another state on different states that had RFAs out there. So I happen to have that list. And reporting is another hot topic that I would love to have something like that. And I think we've been talking internally about whether something like that would be useful. I think our ultimate goal is to be as useful to people as possible. And, in many cases, when it comes to states, it's being able to beg, borrow, and steal, forms and MOUs or whatever else. So that's something I think we'll take back. And I appreciate knowing that would be of benefit. Our tracker does have a list of reports that you can just click on and look at. So the information is all there. I don't think we've really done kind of a thorough analysis of, themes or commonalities across them, but you can find them all in one place.
Thank you.
Any other questions? All right, I guess we're okay. Katie, thank you very much for your time. This was very interesting. And again, as we move forward, we may be reaching out to you to ask for some other presentations from other states or that information. So as we move forward with making our decisions, as again, I think you said it, there's no need for us to reinvent the wheel. If somebody is doing it really well, we can certainly piggyback off of that and use that to meet our needs. But I certainly do thank you for your time. It's been a pleasure. And I will be listening on Friday.
Great. Well, thank you so much for having me, and thank you for the work you're doing.
Oh, you're welcome. Thank you.
Thank you.
Thank you. All right. Thank you. A lot of information between the whole thing. All right. I did have an agenda somewhere. Here we go. All right. What time is it? All right, I got plenty of time. Remember, I need at least 15 minutes. I'm just telling you.
Do you want to go next?
No, you can go. I'm just telling you. I need 15 minutes, at least 15 minutes in the end, just to settle some stuff. So I believe this is for you. Give us the 2023 opiate settlement update, settlement payments received, and recovery funds distribution options.
So this will be shorter than past presentations by me. Again, it's Brendan O'Neill from the Attorney General's office. Much of this information you've seen before. Okay, so the lay of the land is these are the settlements. The distributors and Johnson & Johnson settlement is the one that's currently online that has provided the funds that the council has available to it now, and that has provided funds throughout the state to counties and cities and towns. Purdue Pharma and the Sackler family still waiting for appeals on that to come out to resolve. Mallinckrodt, the bankruptcy, I expect that the funds from that should start to be distributed in Maine in the next 2 months. It won't be substantial funds, and we'll go over that in a few minutes, but it will come with it substantial for some reporting requirements. And I want to flag that because it's one of the only sources we have of reporting requirements, both for the council as well as for anybody else that gets the Mallinckrodt money, which includes cities and counties and towns. Endo is a bankruptcy, manufacturer in bankruptcy that's still working its way through the process. Looks like it might be the fall when the bankruptcy itself might settle up. I'm not sure when funds would come from that, but I don't expect that to be significant funds to me. And it'll be spread out over years. And then the last bullet is the 5 settlements that are currently pending, subject to an allocation agreement here in Maine, which is, when I say allocation agreement, I'm referring to the MOU that we keep referring to about how the money is distributed, the 30% pot, the 20% pot, the council's 50% pot. And those 5 settlements are again with the 2 manufacturers, Teva and Allergan, and the 3 pharmacies, CVS, Walgreens, and Walmart. Again, the recovery fund is currently holding $14,389,348 as of the end of March. There haven't been any further additions to that, but I will go into what the council can expect for additional funding and when in a couple of slides. So that's the council's County. Just to refresh everyone's recollection, this is the amount of money that's distributed throughout the state. This is the 30% pot under the MOU that's distributed throughout the state directly to cities, counties, and towns. And as Gordon has pointed out in the past, for example, if you look at, Cumberland County or York County, there's a single dollar amount, but it incorporates money that went to cities or towns in those counties, which are represented by the dots. We just didn't break it out for this purpose. So that's about 6.7, just under $6.7 million that has already gone out to cities, counties, and towns throughout Maine and Ware.
So in all of Penobscot County, only 2 cities received funding out of that, and the rest went to the county?
That's right. And then Piscataquis of Monalto County.
They went off?
And Aroostook.
Interesting.
Somerset. Franklin, Oxford,
Lincoln?
Hancock, Washington. No, Washington.
No, Kells.
Kells, yeah.
Like one dot. I thought it was a blip there for a minute. So I
Yeah,
thought it was
no,
a
I
fly
know.
on the
Right. Just a little spot. Okay, and so this is payments to date and this is from the distributors and J&J settlements.
So that's money in hand?
Money in hand.
Okay.
And I've talked to people in communities throughout Maine that have received this money, and they're actively engaged in trying to figure out what to do with it. Many of them are going through the same analysis that this group is, asking similar questions or wrestling with what to do with the money. There was an article from the Bangor Daily News that I circulated to this group that talked a little bit about Piscataquis County, no, Aroostook County. Yeah, trying to figure out, doing some thinking about what to do with its money. So people are, throughout the state, engaged in thinking about what to do with this money. And there's, obviously opportunities to be part of that conversation. This slide, this is the sort of global overview of the money that is in Maine or coming into Maine over the next 18 years. Again, this is a review because we've seen this before. The first line, distributors and J&J, will bring in a total of $131 million over the course of 18 years. 65 or 66 million to the Recovery Council over that time period, about 26 million to the Attorney General's 20%. The subdivisions will share amongst them just under $40 million. Carved out of that already is about $2.8 million for an attorney fee backstop fund, and then the last column shows the amount of money that the distributors and J&J settlements set up at the national level for attorney fee funds. And just a reminder, that's 1.8 billion as opposed to the other numbers, which are billion. Maine's not getting billions. The next line is Mallinckrodt, as I mentioned, not a significant amount of money that's going to come in over the term of that $5.8 million. But it does have required reporting requirements about the use of its money. Purdue, can't say yet. The next three, Walmart, Teva, and Allergan, CVS, and Walgreens, will bring in 14.2 million from Walmart, 31.7 million from Teva and Allergan. CVS and Walgreens will bring in about $52 million. So in total, those three settlements will add roughly just under $100 million on top of the distributors of J&J 131 and the Mallinckrodt 5.8. So the total, at the end of 18 years at the moment is going to be 235 million is my estimate. Those last three settlements have asterisks because those are estimates if we have 100% participation in those settlements. If not 100% of the cities, counties, and towns participate, those numbers go down. And so I can't estimate how much will be, because the settlement deadline is next Tuesday. And not all the cities, counties, and towns are signed up for certain for those settlements. So there's some uncertainty about those numbers. And for the council's purposes, the 50% pot, and so let me back up. Assuming that those settlement funds are distributed according to the same percentages as the existing MOUs, that's what these numbers reflect. That allocation is, I have every reason to expect that's going to be the allocation, but there's still work to be done that our office is doing about how to allocate those funds. But it's my expectation that it'll be 50, 20, and 30. So if we get everybody signed up, those are the numbers we're talking about. If it's not everybody, the Recovery Council funds go down. And then the column for backstop fund is left blank because we don't yet, that's a piece that we don't yet have resolution about in terms of negotiating the MOU. So we don't know whether there will be anything in that column and what it would look like. And then the last column, again, is the attorney fee funds. It essentially doubles the attorney fee money that was available through distributors and Johnson & Johnson. So the line item on the bottom, the total, again, 235 million could come into Maine over the next 18 years if we get 100% sign up. 117 million or so to the Recovery Council, about just under 50 million to the Attorney General's pot, about 70 million to the subdivisions. The attorney fee backstop fund is uncertain at the moment, and $3.6 billion is available at the national level for the national attorney fee pot. For the next slide, again goes over the timeline of things. 18 years is the longest window I've talked about. Mallinckrodt, I talked about it being not a lot of money. $5.8 million distributed to Maine over 9 years, not a huge amount. So it's not going to move the dial too much. Purdue's unknown. Walmart, Teva, and Allergan, we've talked about those in general, and Walgreens. And in general, it's 15 years. That's the longest time frame for those 5 new settlements. Walmart is depicted here as 1 to 6 years because if we do get 100% sign up, we're able to get the entire payment that we would be eligible for this year. It's broken up into 2 payments. The first payment will come this summer. The second payment would be later this year. And then this reflects this just basically takes the information I showed before and moves it around the state. So this is the statewide subdivision pot if we get 100% sign up. So this is the 30%. I circulated to the council a spreadsheet of how much each eligible subdivision could get. And this just depicts it about where it would go. So just under $30 million is the potential that could be distributed over 15 years around Maine to these subdivisions.
Again, do those numbers include the subdivisions, cities?
Correct. So this includes, as with the prior map, it's not just county money, it includes the cities and towns within each county. So it aggregates it up. But again, the numbers change and go down if we don't have 100% participation.
Can I ask a question? You said if we don't have 100% participation, why would some of the counties or municipalities not participate?
Let me break that down a little bit. All the settlements have a structure of the payments. So the payments are broken down into base payments and incentive payments. The base payments are guaranteed money that's going to come into the state, and I'll go over that, I think, on the next slide. The incentive payments are designed to encourage cities, counties, and towns and states to work together to get everybody in the state who the defendants identify as eligible. So it's generally subdivisions of 10,000 population or larger. The defendants want all of those subdivisions in the state and anybody who litigated against them to sign up. If they get 100% sign up, you get the most money. And that includes, that's not just, so it's anybody who is 10,000 or larger, who is either litigating or not litigating. And then anybody else who also litigated, so you could be below 10,000. Or as the case is in Maine, some school districts are litigated. So the defendants want releases from those. So those two groups, the defendants want 100% sign up in order to get the maximum to come into Maine. And this is true of every state. So base payments and incentive payments. There's a limit to what I can talk about in terms of I don't know that I can answer your question of why, because in this capacity here, I represent the council and its work. And I'm trying to advise the council about, it's about the recovery fund and about its work and things like that. I also work with the Attorney General to work with him on how to implement the settlements and how to, that includes working with him to encourage sign up for, so that we get 100%. That requires me to, work with counsel for litigating subdivisions. So there's a limit, because of that role, I can't really get into that role because there are litigating subdivisions present in this room, but their attorneys aren't. And so there's a limit to what I can talk about in terms of why, a subdivision wouldn't want to sign up. I think probably that's that. Okay, but it's worth saying that at this moment, we don't have 100% sign up on those 5 settlements. It's still up in the air, coming down to the deadline on Tuesday. We're hopeful that we can make progress between now and then and get 100% sign up. Thank you. So this is the chart that shows the payments that are going to come into Maine in 2023. The first line, Johnson & Johnson, is something that stands out because it's pretty small. It may not be what you expect, but you may recall that the Johnson & Johnson settlement was structured to front load several years worth of payments. If a state meets the 100% sign up threshold, that's all of the incentive payments. Maine was able to achieve that in 2022. So as a result, we got all the incentive payments, and therefore we front loaded. We were able to get paid into last year the first 5 payments. So what is left is just a bit of a stringer payment that comes in under sort of a line item of the settlement, and this $201,000 will be allocated across the state in the same way that other payments, so 20%, 50%, 30%. What this doesn't reflect, because I couldn't figure out how to do it with any level of accuracy, is that our office and counsel for the litigating subdivisions work together to make available to the subdivisions the option to spread out their lump sum payments or annualize their lump sum payments over those 5 payments. So some subdivisions elected to not get their money as a lump sum and to instead spread it out over in equal payments over those 5 years. I haven't yet updated the AG's website to reflect those dense charts that I put up there. They have to be updated to show, which of those subdivisions did that and what their payments would be. But they will get an annualized payment. But for the rest of us, it's that $201,000. Distributors, I expect will, and so that's, J&J will come in June 1st, and that'll just go directly to participating entities. Distributors, we expect the payment on July 15th. That'll be $5.6 million, again, distributed throughout the state. Teva, Allergan, Walmart, CVS, and Walgreens are all, the timing of it is dependent on when the settlements become effective. And that depends to some degree on steps that have to be taken between next Tuesday, which is the sign-on deadline, and roughly the end of June. The settlement, if the defendants have to do certain things, the settlement administrator has to do certain things, and then we'll know the effective date, and that will decide when money can go out the door. But these payments here are the base payments, so they're not affected by sign-on. That money will come into Maine one way or the other, but how it's allocated throughout Maine will be uncertain if we don't have that agreement by next Tuesday or by the time these things come. And so let me back up. A fundamental rule under the settlements, and this is the term of the settlements, is that the council and anybody else who receives direct payments from settlements cannot pay settlement money to a non-participating subdivision. So if a city, county, or town had the opportunity to sign up, didn't, the council and nobody else in the state can pay settlement money directly to that entity. That entity can benefit indirectly from the application of the funds, but they can't get a payment from the settlement. They can't get a payment from, or they did get a payment.
Can they apply for grant dollars?
They can apply, but the council would not be able to give them a grant.
So if I was a town, I'll just pick a town. If I was Augusta and I said, I'm not signing in. So when we we set out an RFP for grants. Someone from Augusta applies for that. You're saying that we cannot fund that because they weren't part of it.
Yes, and to break it down a little bit further, the council has money coming in from several settlements. There's going to be 7 right now, plus 2 bankruptcies. So the Johnson & Johnson distributors money doesn't, has that same rule. And if a city or town or county signed on to those 2 settlements, but not the new 5 settlements, then the council has to kind of do that accounting to say, well, they can get money from these 2 settlements, but not from these other 5 settlements.
And does it matter that I'm an agency located in a non-participating town? So I have a program, I'm crisis and counseling, and I'm here in Augusta. Augusta didn't apply, but my agency is located in Augusta. Does that discount me from those funds?
I believe there's support in the settlements that the answer to that would very likely be yes.
Interesting.
What if you're an agency like?
That is.
So in other words, a department within a city, county, or town that didn't sign up is part of that city, county, or town.
Even if I'm a private.
What if
agency?
she's saying a
No,
nonprofit?
if you're a nonprofit.
Not a nonprofit.
Right, no, if you're geographically located there, that's
Yeah.
not.
Then that's, right, if I'm a nonprofit in Augusta.
I was
Augusta
like,
didn't
whoa,
apply.
No, we're talking about entity level. I'm thinking of entities. If you're if you're part of the entity of whatever the city, county, or town is, if you're that department, or if you're a board or commission, or things like that, of that.
So if I'm from the Augusta Health Department, and Augusta didn't apply, remember, I'm not making this up, Augusta, then I wouldn't receive, but if I was crisis and counseling, which is a nonprofit. Okay, look, I am, okay,
That would be.
and then I'm only, the sign up is only with the ones that had the MOU that said you had to sign up. Not all of those have that stipulation that I had to join in.
There's two answers to that. One is, depends on the outcome of the sign-up deadline, which is next Tuesday. We're, hopeful and optimistic that we'll have 100% sign up. The other answer is that, I was planning on talking about this in the next segment. When the council decides to give out funds, I will recommend that it include as part of its contract, some sort of affirmation from the entity that if it's a city, county, or town, or a school district, that it either has released, either has signed a release for these 7 defendants, or if not, that it is willing to sign a release for these 7 entities. If it hasn't, it has to sign the release in order to participate in the contract, take that release, and then it's done and can participate in all future grants, really at any level. But it'll be my suggestion that we incorporate into the contracting that question: did you sign a release? And if not, please sign these 7 releases, and we'll get you get those upstream.
Thank you.
Okay. So coming into the state of Maine, to wrap up this slide, a total of $18 million, just over, is expected to come into the state of Maine. How that's allocated at the moment is still uncertain. But the first 2 lines, at least, we know how that'll be allocated. It's the 30, 20, 50. And so more information about the settlements, you can see our website up there. Any other questions on this slide? This is really for the next segment, so which is item number 7. Or I think it's actually number 8. So the last section I have is to talk about recovery fund distributions, options, and next steps. I've been doing some research in my office and talking. The council has a great deal of flexibility in how it distributes its funds. It has a good deal of it has a good deal of discretion in how it distributes its funds. And some of the options that are available to it are, it can make a single payment to an entity that it wants to support the work of. It can enter into a contract with a non-state entity, like we talked about, a particular provider of stigma prevention services, or it can run a larger grant program, or any combination in between. I have been working on developing a uniform contract for the council's distributions, and one that can be adapted according to the situation. I've also been trying to gather information about grant procedures. The council, isn't, it has the ability to decide, using the procedures in the MOU and in the bylaws, that it wants wants to make a distribution of X amount of dollars to, Y agency or entity for Z purposes. It is bound by, it's gotta be abatement uses, it's gotta be, by a vote. Can't exceed the amount of money it has available to spend. And there's probably, good practices that the council ought to follow, like collecting data, requiring data to come in from the entity, and lots of other things that many of you know about that I probably don't. But it can make a decision to say, this, once the council identifies what its mission is, what its priorities are, what it wants to do, it can identify a particular provider or entity or whatever, and say, we want to support what this organization is doing, or we want to support, do a larger grant program, and say we want to support this kind of activity throughout the state and invite applications. So there's a lot of flexibility, and my next steps are I'm going to be working more on putting together this sort of uniform contract. I'll need to make that available to the council for its input, and make sure that it meets the requirements of the MOU and has whatever best practices you all may want to provide. And my goal is to have that done during May, because I'd like to get it to the council for its review, because ideally I'd like to be able to put the council in the position of being able to make a decision on getting a payment out the door by the end of June. For me, that's going to be a lot of work between now and then. And I'm going to be trying to get that done as quickly as possible, but that's a personal goal. It's not meant to be a goal for the council. I think you need to decide, whether you have the information you need to be able to make that kind of decision by the end of June. But I want to make sure that the council is at least in the position to be able to make a distribution. And that's sort of my time. The step that has to happen before that, which I think I referenced in my email, is there needs to be a conflict of interest policy. I'm working on that. I need to get that to the governance committee, for review, and so there, that's the very next thing on my list to get done, and I'm hopeful I can get it done within the next 2 weeks. So that, I don't have a great deal of report on that section, but that's sort of where things are.
Just ask a clarifying question, because I think it'll dictate how we do our work here in the council significantly. You said that we could pick a provider to fund directly, which, just in my perspective as DHHS, that is off limits. I do not have the authority to do that. We do everything competitively per procurement laws in the state of Maine. So I think I would just want to better understand where that authority comes from, because if we're going to get in the business, if we A, have the authority, and B, we choose to exercise that authority to pick basically who we want to fund directly, that is going to come up with a lot of different political ramifications and other issues as well.
Yeah, and that's glad you asked that. It's something I'm still working on. My initial review suggests that the council's authority is in the MOU, which gives it the authority to direct its funds statewide. The council has the ability in the MOU to make a decision about the disbursement of funds statewide. If the council may decide that running a competitive process for even a single grant, council, it may want to decide to say, we'll do a competitive process, we're going to fund one chunk of money to one entity to do the following thing, but we still want it to be competitive. That's a decision the council And, there's a lot of good reasons to do that. The council can decide to follow the procedures that are already in place in the state of Maine. And there's good reasons to do that.
There's a lot of landmines that people live with. I will tell you that I live in Bangor, and don't ever mention the money to the Portland Recovery Center carefully in Barn, because the state sole sourced it, and Barn has been resentful ever since. And since then, they've branched out in all sorts of programs. So again, yeah, I think it's a caution that we have to do. I think part of what Brendan is talking about is that, it's nice to know that we've done something with it, that with our money, and I think that's important for the community to see that we haven't just sat on this, money and that we want to get it out. But we do have to be cautious about how we do that, and not just look like we have pet projects or, again, there's a lot of political landmines to be very cautious of.
I mean, to that end, I think going back to, which I appreciate keeps getting printed, because I think going back to this, there are 5 principles, and that's spend the money to save lives, use evidence to guide that, invest in youth prevention, focus on racial equity, and develop a fair and transparent process for deciding where to spend the funding. I just think that if we follow these guidelines, we should avoid most of the landmines, and
I think so.
And also do some of the other things that I think we all keep talking about, but I think it's like, I just think if we keep going to this, it'll be really helpful.
I think so. So,
Yeah.
do you have more?
But just to that point, I think one of those principles is don't spend the money right away. And it's something I intended to say, which is the council's got $14 million in the bank right now. We talked about, it'll have 131 million coming in over 18 years. Ideally, that'll be increased by $100 million over another 15 years. So these are big numbers, but they're coming in over 18 years. And the problems that the council is working on will not be gone in 18 years. So there's an argument for this is, a significant chunk of money, but it's limited money. And once it comes in, there won't be more from these particular defendants. And so, and there's no requirement to spend the money all in a particular year. So as the council does its work and considers what to do, there's no need for the council to spend all $14 million right away. But on the other hand, it may want to in order to jumpstart, or provide a lot of fuel to the work that's going on around the state that we heard a lot about today. So
We are interest on our money in the bank.
that's another thing that I'm looking at, whether state law may know the answer.
What can we do with the interest of our money?
I would have to reread the statute. I don't know if it is an interest-bearing account. If it is, we would earn interest. I know that certain accounts do it.
I think it'd be wise to put it in an interest-bearing account,
Yeah.
but.
I'm confident that if the money is put into an interest-bearing account, I think other states are even thinking about, can we invest them for larger returns? The gains, the interest and the gains, stay with the council, stay with the fund. They don't go to the defendants.
So they last longer.
That's, yeah, I mean, like, you could, it's possible that the council could treat it like a trust fund. Use proceeds, but there's a counter argument that the money's there to be spent to save lives.
Yeah, I really, I think we have to be responsible and prudent with the money. But just listening to Sarah, which was outstanding, she's amazing. But the needs are huge and they're so identified.
Mm-hmm.
So I think that that'll help us with sort of just, I learned a ton and I worked hand in glove with OBH, it was just, so I just think the needs we have a better sense of the needs and people are suffering. And we're not really moving the needle to Gordon's, like where it's
Yeah.
I don't want to use the word stable because it's not, but because one loss of life was not good, but today has been great. I just feel like it's been a ton of information.
And the settlements reflect a mix of opportunities. On one hand, the settlements will pay out over 18 years. All of the settlements most of the settlements are to some degree or another front-loaded to the earliest years. But, there's a longevity there for sustaining work. Also, some of the settlements are designed to be significantly front-loaded into the first years to fuel those existing efforts. So there's a mix of opportunities there.
Just a reminder on time.
Yes.
Sorry.
Yeah, 'cause you have one.
I got a 5-hour drive and I got.
Okay,
Oh my
so I would like to have a conversation, a quick conversation, doesn't have to be long, about spending a portion of your money. So a portion of your money can be spent, the money here, our money here, can be spent on administrative purposes. And what I'm learning in this short period of time and working with Brendan is that we could really use some administrative help with a strategic expert, with somebody that would work directly. It's wonderful to work with him, but he has other responsibilities. I would like permission from here, or a vote, that we talk about hiring a consultant to work with the group for at least 1 year. And we could do that, we'd have to run a job description, put it out to a bid, interview people. Hopefully, there's a few people in the state that I think have a real knowledge base of substance abuse, as well as they are strategic experts. But I need to do that. It's not my decision to make, to hire somebody to work with this committee. Brandon, of course, would always be part of it as a member of the AG's office, as the lawyer for the council, but we would engage in somebody who would be the administrative person to work with us.
Would that person help to facilitate meetings and things like that? Yeah, I'd be all for it.
Strategic plan, help us make decisions. Say, for instance, we say, okay, we want to do an RFP process. This person, we could say, can you research some of what you see other people do and how they do it? They could bring that information to us. We'd make that decision. Again, it would be the person that we have questions, we want research done, they do it to us, and then bring it back to our committee. And I'm suggesting that whoever that person is, we probably have a contract for a year. And then after the year, if you want to continue with that, you can. If not, we could just discontinue the contract and move forward. But it's what I'm discovering. It just seems like, we want to spend this money, we want to do it strategically and mindful, but how do we do that and how do we get to it? So that was my thought process, that if a couple or one person or whatever like to work with me, if you're in agreement, we would write a job description for what we're looking for, bring it to the committee, and if they approved it, then we put it out to like a bid.
So can I ask to clarify, just with the money, do you two feel like you're the identified staff?
I will soon not be.
Okay.
We are bringing someone else on into our division who's hopefully going to be able to offer you guys some more support.
And does that look like?
But that's like my, we'll work together, but I'll be able to work harder.
But to reinforce what you're asking, Pat, there really is, you don't each have 20 hours committed a week to this project, this 20-year project. Is that fair?
I mean, the council is a significant part of my work. And moving the council forward is, one of my, if not the top priority that my job tends to be focused on the opioid settlements, both helping to administer it and advise the AG in our office, and also, working with the council on carrying out the settlements.
So that's sort of not to put words in your mouth, but I see you're a leader.
I'm the attorney.
And then what you're asking for, Pat, is help for our leader in the council?
Correct.
I think that's, yeah. So go ahead, Brendan.
Yeah, I see a slightly different structure. I mean, I'm so I provide legal counsel, but what I hear Pat talking about is an administrator, or, it's somewhere between, like, maybe it's not a full-blown executive director, but it's somewhere else. We had a presentation today from Nashby. That could be a great resource to see how other states are staffing this group. Another thing to consider is how, if we all have experience with this, how other sort of analogs to this council in the state of Maine staff, like, for example, Maine Health Access Foundation, I've looked at a bit. They have, staff, and there's other philanthropic, entities that distribute money, and quasi-governmental entities that distribute, like, efficiency Maine. OBH distributes money, they have an extensive set. How the council, so there's information out there about how this group is staffed in other places or in other analogs that the group probably ought to look at as it, considers these things. Also, one announcement is that Haley just made the announcement. We're bringing on paralegal. This person is going to start on Monday. A paralegal is, somebody who is going to help me with sort of, help me get the legal work done.
Actually watching
Eager, we like it.
We'll introduce her at the next council meeting, which is one of the topics on the agenda. I anticipate, and maybe this is something we need to do down in the office, still asking Haley to help out with, everything she's been doing. So there will be, additional administrative support for me and for the council in our office. But I think what I hear Pat talking about is different from, like, administrative support. I think it's an administrator or an executive director or something like that. But there are, it's probably a good idea for council members to look and see what's being done in similar entities and see what you want to do.
So would you consider, I'm just throwing this out there, would you consider an individual from a particular agency that has talents in these areas, or would you want an individual who is independent?
We would write a job description as to what the duties were, and if there was someone within an agency that had the time.
Maybe it was supported by the agency.
Correct, to do that, that could be there are people who have their own businesses and that's their expertise, they're strategic experts, that's what they do. They come in, they're consultants, they're experts, is what they do. Again, first we have to say, are we willing to spend some money to do this? And we have to have a job description because we need to know if we're going to approach somebody on what to do, we need to know what those responsibilities are and then move forward. But if the council doesn't want to spend any money on this, it's a viewpoint to move forward. And so that's the question. Do you want to spend some of your, and again, you have a portion of your funds that can be spent on administrative tasks.
And there may be, sorry, one just technicality. That's usually what.
Oh, no, go. Okay, I'll wait.
I just wanted to say, I've been looking at whether it can be a contract as Pat's described. That if it's over $5,000, it's my understanding we would need to advertise it for applications, and we need to, consider the applications. It's almost the same timeline and process to have a full employee in our office. So, contract versus an employee, the council doesn't need to make that decision right now. It could be something that gets done over time. But if we're trying to, bring in a particular person on a contract, that's a technicality that I think we need to, at least I need to pay attention to. Sorry, that's.
No, it's okay. So what it comes down to though is how fast do you want to move? I mean, no offense, but you guys have other things to do. And if you have somebody who is dedicated to this, then they don't have something else to do, and they can do chop chop. So I would be in favor of chop chop.
Yep.
That's my motion. How's that? Motion is
Make
chop.
that motion.
Chop chop is the motion.
How much money are you estimating this would cost?
I have no idea.
I have no idea.
I have no idea. I tell you, I know people who do consulting work. I can certainly ask them what a norm to charge would be. We know how much money we have, and so we could look into that. We could actually look to see if there were some here, our state employee, there's guidelines as to what you can pay people in certain positions, and we can look at that. But again, the time is running short to sort of do this, and so that's why I'm saying if you are willing by the next meeting, if I can get one or two people just to either telephone with me or whatever, write a job description as to what we think at the next meeting, I can bring that. We can edit that out, go there. I can do a little bit of research on salaries. You can do the research on whether, it's a contract versus an employee of the Attorney General's office, and then bring that to discussion at the next meeting.
Can I second the chop motion?
Yeah, thank you.
So, I appreciate that, I'm gonna try to translate the chop motion.
Okay. I like chop.
I understand the motion to be,
Little parentheses, chop.
yeah, to,
Oh, great,
Nice job.
forever immortalized.
so it's a motion to, spend recovery funds on a contract for an administrator. Anybody want to amend that?
Let's see.
It's been amended,
Parentheses, chop.
yes, it's been amended to chop. All right, if there's no other discussion, can I have a vote that we move forward with this? All right, any abstains? No? All right, thank you very much. Now, does anybody want to volunteer to do a job description with me?
That's
Courtney.
Okay, no problem. I will get a hold of you, I have your email address, and we'll do that for you, okay? We'll do that, all right.
I'm all over.
Next thing on the agenda, we need to elect permanent offices for this
What's the?
committee.
11.
And what I'm suggesting is that I ask a few people in between now and the next meeting to serve on a governance council. That committee will get together, we'll put out an email to people and asking people if they want to serve offices. And then present those, and the governance council will meet. We will determine what we need from people who are applying for the offices of the positions, for instance, a short resume, and do that. And then hopefully by the next meeting, we will have a slate of offices, permanent offices, to vote on for the next year. Done. That sound like a plan? Okay, so I need people to volunteer to be on a governance committee. Now, according to the bylaws, I can appoint. But I'm looking for volunteers.
We have one, right? Is that what you're supposed to be decided?
We don't have a governance committee.
Oh, I thought that was a bylaws committee?
Oh, the bylaws.
That was an ad hoc.
It was an ad hoc.
Got it.
Put Gordon on it.
Oh, Gordon wants to be on it,
Because
okay.
there are 4 members who aren't present.
Okay, Gordon?
Yes,
Anyone else?
I feel like Courtney
Yeah.
would want to because she wanted to be vice chair when
Okay.
we started this, so.
And it doesn't mean if you're on the governance
Right.
committee, you can't put your name in the hat to serve an office. We have 2, I will serve on it as chair, as interim chair. Anyone else? She's not, I will ask her.
We're just sending the rules.
Oh, look, the meeting has to end, my pen is out of ink. All right, all right, so we have a governance committee, they will meet between now and our next meeting. You'll see an email that will go out asking people to volunteer if they want to apply for one of the officers' positions of the council. And the governance committee will look at that and they will present at the next meeting. We may ask people to do a short description, short, wouldn't call it a speech, but say something about themselves as to why they want to serve in that capacity. And then we will take a vote. And then we'll move forward. Sound reasonable?
Yes.
All right, that's done. All right, what was my next one? The proverbial next meeting. You all got an email asking on dates and time which work best. Why do I don't remember this email, but
No,
It's lost in all the email.
Surveys.
Everyone did except Betsy.
So.
I did.
Oh, I did do it.
No, Betsy's the only one, I think, right now that we were supposed to.
Betsy was the only one that, the rest of you. All right, so.
It was in Tuesday's email. It was on-
Oh,
It's
okay.
hidden in all the.
Okay, so.
It was a link to a
The
survey.
issue is, do you know now that you have a date or time that you'd like to do it, or do you want to complete the survey and then do it? And then whatever that survey says, we will meet the next time.
Survey.
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 Okay, because I'd like to have a meeting, is this April? I'd like to have a meeting, this time of year, I'm a little crazy. I'd like to have a meeting in May. So somewhere, George, start looking, so we will look at that survey, we'll get it out, we'll get you a date. I'll get a date for the governance committee, for those who volunteered, and for those who volunteered other people. You get that out, and then hopefully at the next meeting, we will have a slate of officers. We'll discuss the job description for an administrator. There was something else that you want to bring up, oh, you want to introduce our paralegal, the paralegal to the group at the next meeting, and what else was there? I think that was
Once
it.
we think of it, we'll.
Oh, the other thing I want to talk about at the next meeting, I think, is to talk a little bit about what we can do about Zoom options.
Remote.
Yeah, we want to talk about remote meetings, because people are traveling long distances and it's Maine. So I would like to have that on the next agenda, that we talk about how we can do that better for people. I like in-person meetings, but, you know, I only travel an hour, everyone, we're traveling more than an hour, so. All right,